we skip that step of, is this malaria? And we just go straight to the pharmacist and we're like, I need
anti-malaria.
antimalarials.
And then
I
if
need
it
to
doesn't
treat
work,
this.
the tricky thing about this is that there's probably around 50% of the time where you do it and it works because you actually have malaria.
Yeah.
And then that colors your thinking about it.
Yeah.
So that the next time you have something like this and you go and take anti-malaria and it doesn't work, or you're getting worse, then you don't know what is going on, and then you rush to the clinic, and at that time you might be a much worse thing you're dealing with.
Yeah.
Meanwhile, if you'd just gone to a proper clinic originally,
Yeah.
gotten tested, confirmed your diagnosis, you will be in a much better place.
Hello, healthcare enthusiasts, and welcome back to The Cure. This is the podcast where we're revolutionizing the business of healthcare in Africa, one conversation at a time. I'm your host, Tim Topekoka, and in each episode, I sit down with the people that are reshaping the way that we think about healthcare in Africa and the future of healthcare in Africa, from founders to investors to policymakers and beyond. And our goal is very simple: to infuse hope back into the narrative by spotlighting the progress and momentum that's already unfolding across the continent. At the heart of every episode is one key question: what does it take to revolutionize the African healthcare business model? All our insights are powered by TC Health, your trusted source for pharmaceutical and healthcare insights in sub-Saharan Africa. So let's get into it. In season 2, we're exploring what it takes to build the rails: the regulation, the financing, the partnerships, the data, the physical infrastructure that turns a promising idea into scalable and reliable care. Today's conversation is the most literal embodiment of that theme we've had this season. Today, we're sitting with a founder who has spent the last decade building a layer of African healthcare that almost everyone agrees is essential for any functioning health system: diagnostics, the labs, the imaging, the tests that produce the information that clinicians use to decide what to do next. Without diagnostics, every adjacent layer of the health system, from if we talk about precision medicine to telemedicine to insurance, it can't function. And it's a part of the health system that has to exist before most of the conversations we have, even on this podcast, become possible. And in Nigeria, the gap in diagnostics is pretty substantial. Fewer than 300 radiologists serve a population of over 200 million people. The country has fewer than one CT scan per a million people. And the WHO's most recent regional report, so this is for the African continent, says that only about a third of African health facilities have functioning basic diagnostic equipment. And for many molecular tests, samples still need to be flown out of the continent before a clinician can get a result. My guest today set out to solve this problem with an asset-light model at first. He wanted to import refurbished diagnostic equipment from the US, sell it to Nigerian hospitals, and layer a service on top of that. But the market did not kind of let that model work. Hospitals couldn't justify the upfront capital, the payer, the health insurance kind of infrastructure that would have underwritten it wasn't as mature as it needed to be. And the team eventually pivoted to the harder version of the same idea. They built the centers themselves. Soga Oni is the CEO and co-founder of MDaaS Global. He completed his master's in system design and management at MIT and co-founded MDaaS in January 2016. So this is your 10th year.
10th year, yeah.
Oh, wow. But you co-founded it alongside Joe McCord and Genevieve Bernard Oni.
And Okweyemi
Ologun. The company was incorporated as a medical equipment importer before pivoting in 2017 to operating physical diagnostic centers directly. And since then, the proliferation has been quite impressive. So today, under the brand Beacon Health Diagnostics, MDaaS runs 26 company-owned clinics and 40 affiliate clinics across 15 Nigerian states, plus a center in Douala, Cameroon. Did I pronounce that right?
Yeah, Douala, yeah.
The company has served over 600,000 patients to date and ran more than 1.2 million diagnostic tests in 2025 alone. The network now receives referrals from over 1,500 clinicians and offers more than 500 tests. And across all rounds, MDaaS has raised approximately $6.8 million, most recently a $3 million pre-Series A in March 2024, co-led by Aurora Capital Management and Newton Partners, and then follow-on from Ventures Platform. Soga is also an MIT Legatum Center Fellow and was part of the first cohort of Techstars Impact. Soga and the MDaaS team have articulated the company strategy. So Soga sent me a lot of homework. He sent me some pre-reads that I had to brush myself up on. And they've articulated the company strategy in 3 parts. So part 1 is building the physical diagnostics rails for the mass market across Nigeria. Part 2 is then laying the technology layer on top of that turns it into from infrastructure into a coordinated healthcare network. And then part 3 is kind of scaling exponentially through partnerships and data with the long-term ambition of becoming the largest integrated health network on the continent. So the conversation today will move through each part in turn. We're going to walk through the pivot from being an importer to an operator, the realities of running a 60-plus clinic network across 2 countries, the tech, the partnerships that turn MDaaS into something closer to infrastructure than a chain of clinics, how an indigenous operator keeps pace with international diagnostics groups, and just the bigger question of what it actually takes to fund and scale capital-intensive healthcare in Africa today. So Soga, welcome to The Cure.
Thanks for having me.
Really, really glad to have you. Before we dive in, I want to share something exciting. The Cure is partnering with the World Health Expo Lagos, West Africa's leading medical trade event, taking place from the 2nd to 4th of June 2026 at the Landmark Center in Lagos. WHX brings together over 500 exhibitors, 8,000 healthcare professionals, and 30 world-renowned speakers across diagnostics, medical devices, health infrastructure, digital health, and the list goes on. This year's Hospital Investment and Buyer Leadership Forum is tackling one of the themes we care deeply about on this show. How do we build resilient supply chains? How do we localize manufacturing? And how do we create strategic partnerships that strengthen healthcare delivery across West Africa? So we're going to be live at WHX, bringing you coverage straight from the exhibition floor. We'll be interviewing key speakers, we'll be giving you behind the scenes content, and just giving you an experience that you can't get from just a press release. So if you're going to be at WHX Lagos, please come find us, and you can register at www.worldhealthexpo.com. Okay. Before we jump into today's interview, or today's episode, as always, we want to take a couple of minutes to set the stage and walk through the signals in the African diagnostics space today. And Soga, I implore you to chime in, to give me your thoughts, to give me the color that you can only bring from operating in the space on a day-to-day basis. So we'll start with the diagnostics gap. Diagnostics is the part of the health system that produces the information, like I said, clinicians use to decide what do we do next, what is going on with the patient, what will be the best course of action. And the layer is very thin in Nigeria. There are fewer than 300 radiologists for a population of more than 200 million. The country has fewer than 1 CT scanner per 1 million people, compared to roughly 40 per 1 million in high-income countries. So that's like it's like a 40-fold deficit. The WHO's most recent regional report estimates that only a third of African health facilities have functioning basic diagnostics equipment. And what ends up happening downstream is diagnosis tends to happen late. Treatment decisions get made on incomplete information. You have patients waiting for ages because their samples have been shipped to Germany. I've literally had that happen to me before. I'm not going to mention any names, but I went to get some tests done and they were like, yeah, it's going to take around like 5 to 6 weeks for you to get your result. And I was like, why? And they were like, we have to ship your samples to Germany.
Not surprised. I think to add a little bit more context to that, I think when you think about the gap and you mention these numbers, when you kind of split the country and say, okay, most of those radiologists, the majority of them will live in Lagos, right?
Yeah.
And so when you think about the number of radiologists, say in some states, sometimes you're looking at like one person for 3 million people. So it's even worse when you kind of like look deeper into the numbers.
Yeah.
Because look at the CT scan number between Ikoyi, Lekki Phase 1 and VI, you probably have about 25 CT scans there,
Wow.
right? But when you see, or there's some states that in the whole of the states, there's literally no CT scan, right? So when you think about the number, it's not just about that headline number.
Yeah.
When you dig a little bit deeper, it's even worse because a lot of the capacity tends to be concentrated in bigger cities like Lagos, Abuja, Port Harcourt, compared to the rest of the country.
Yeah. And that ties into, and when we get to it, the strategy of MDaaS in terms of when you think of location, when you think of which populations to serve, MDaaS has been quite strategic in trying to identify the populations that aren't as well served with the existing diagnostic infrastructure that we have. So that makes sense when you think about, it's usually concentrated, if we're just going to be very honest and blunt, where the wealthiest people are. That's where most of the diagnostic infrastructure is concentrated. So it really is kind of a class divide on whether you have access to diagnostics that you desperately need if you have any sort of life-threatening illness. So that's something that I think came through in the homework that you gave me. I was reading through a lot of the way that MDaaS thinks, and I can't wait for us to unpack that later on in the episode of how exactly did that strategy and that thinking come about. But we also have the NCD wave that's reshaping the demand for diagnostics. So Nigeria's WHO non-communicable disease or NCD profile attributes about 29% of all deaths to non-communicable diseases like cancer, cardiovascular disease, and diabetes. And the WHO has projected an almost 30% rise in Africa's NCDs over the next decade. And that's faster than the global rate of 17%. So the global rate of NCDs is rising at 17%. Africa's is rising at almost double, at 30%. We've also seen recent Nigerian survey data that places our diabetes prevalence at around 12.7%. Hypertension at 14%, and obesity at 25%.
I think hypertension is probably higher.
Really?
Just from looking at our own data, internal data.
Where do you think hypertension is?
I think it's going to be, around the bigger cities, when we look at our numbers, I think it's probably like 20-30% in the bigger cities.
Wow.
Of the people we screen at risk of or already on the way to hypertension, because you have stage 1, stage 2, and then hypertensive crisis. So you're already saying that, like, if this person doesn't take care, they're going to have an hypertensive crisis soon. And these are all really young people that we're screening. So it's kind of quite worrying.
I was going to ask, what is the profile that you're seeing of people with hypertension? It sounds like it's young people.
It's young people, old people. Like it's really a wide range of people. It's people because we tend to do a lot of annual screenings. For folks, and that's where we can see, and that's one of the basic screenings we do. Like like just checking people's blood pressures. And so that's something we see that, in bigger cities, the prevalence is much higher than everywhere else. Like
what do you
Lagos.
think it is about big cities that
stress? People are more stressed. People are working themselves to that. Literally sometimes. And so I think, there's just a lot of more things to people don't eat well. I think for the NCD burden that is increasing, I think a big part of this is that we're changing our diet, but we're not changing the lifestyles. We're still eating food as if we are farmers, and we're not quite farmers anymore. We're office workers now. And so it's some of it, and some of it is just people are not just in the know of these things, because with NCDs you feel okay till you don't feel okay. So people don't tend to do a lot of preventive care screenings or just the regular checkups. So that's one thing that we're trying to change, is how do we ensure that our people do more regular checkups, so that when you pick up on a sign, you can start working on it. So very important.
It's interesting, the diet points, because I saw a few weeks ago on TikTok that somebody was saying the actual portion of rice we should be eating versus what I know I eat as a portion of rice. Like any Nigerian can attest to rice and stew. Rice and stew and some sort of fried meat, fried chicken or whatever. The mountain of rice that we eat
It's a lot.
versus the size that is actually a portion of rice. I was like,
But I will push back to that because I think in Japan, right, people eat a lot of rice too.
yeah.
Right. And, they're the healthiest country. They're one of the healthiest countries at least. But I think it's also about like physical activity, the culture of engaging in a lot of physical activity and creating time to do that.
Yeah.
And having a more balanced diet, not just eating rice, eating other things, and balancing your food with some vegetables and everything.
Yeah.
And so I think the diet is one piece of it, but I think also like the stress levels in bigger cities are definitely higher. People live very sedentary lifestyles. So people also need to change that, with the diet.
Yeah.
So.
And Nigeria is also just like hot. Like I was speaking to someone at a large pharma company, and they were talking about how some of the work that they're trying to do some research on is the impact of climate change on health outcomes. And one of the things that they notice is, especially in sub-Saharan Africa, as global temperatures rise and it gets hotter, they're actually seeing a correlation with things like cardiovascular disease.
Wow, that's interesting.
So when you think about, like you mentioned, people working themselves to death in some cases, when you're out in the sun from morning till sundown, that level of heat stress, dehydration, just the general what heat does to your body can actually affect your heart. It can, like we hear about heat stroke all the time.
Yeah.
Like in London or New York, when it's July or August and there's a heat wave, there's all these like public notices about heat stroke. Make sure you have water on you, etc. But the temperatures then are like a normal week here in Nigeria.
Yeah, that's fun.
I know we've adapted, we're used to it, but as the
we can get
temperature
heat stroke here
rises,
too.
right.
Yeah. Some people do get heat stroke here too. So that's something to note.
Yeah. But yeah, I think there's quite a lot in terms of the rising chronic diseases in not just Nigeria but in the region. I think diabetes alone was estimated to cause 40,000 deaths in Nigeria in 2024, and I'm sure that number is rising. And so what this creates is a need for diagnostic touch points. Like all these diseases have some level of test that you need to kind of diagnose the condition that's happening. But one thing I wanted to point to, because we always want to point to hope and things that are encouraging, is that policymakers are starting to take the financing side of chronic disease more seriously. And particularly in Kenya, the Social Health Authority expanded its cancer care package from about 550,000 shillings to 800,000 shillings, effective the 1st of December 2025. And this was part of a presidential directive with a publicly stated plan to raise that cover again to 1 million shillings within 3 years. That's the equivalent of over $7,000. Obviously, $7,000 in this context is a lot, but when you think of the cost of treating some of these conditions, especially when they get quite severe,
it's much more than that.
Yes.
Yeah.
So this is the kind of policy that, if we see this kind of proliferating across the region, could turn the rising NCD burden into a financial demand signal that diagnostic networks have been waiting for. Like, not just we're seeing chronic disease rise, but we're actually seeing serious policy attached to meeting that demand and making sure that there is kind of an affordability to it and patients have access to care. We'll touch on that later, because I would love to understand from your perspective, your touch points at all with the public sector and what any moonshot aspirations are on the public sector side. But speaking about the public sector, there's also a genuine movement from that side, from MedServ. So MedServ is the wholly owned healthcare arm of the Nigerian Sovereign Investment Authority. It has its healthcare expansion program that it flagged off in August of 2024 to establish 23 additional diagnostic centers, 3 oncology centers, 7 I'm going to mess this up, catheterization labs across, cath labs across Nigeria. I don't know why I typed the whole name, but 7 cath labs across Nigeria's 6 geopolitical zones. In February 2026, the IFC, the International Finance Corporation, and NSIA signed a Naira-denominated financing deal to fund this expansion. And so the oncology facilities are expected to serve more than 2,000 patients on an annual basis, and the diagnostic centers are projected to reach over 350,000 Nigerians a year. This is an example of sovereign and DFI capital being deployed to infrastructure at scale. And that's exactly the part of the system that MDaaS has been building from the private side. Yeah. So very interesting to see kind of all these things kind of coalesce. And then we just want to talk about the growing markets, the growing diagnostics market in Nigeria. So Nigeria, and you would know more of these stats, so please feel free to kind of push back. But Nigeria's clinical lab services market was valued at roughly 500 million in 2020 and is projected to reach over 650 million by this year, according to some recent intelligence reports. Within that market, the biggest gap in demand is mass market and structural. So according to this industry data, roughly 70% of African health clinics lack the equipment to perform basic diagnostic tests. Even within the organized diagnostics market, as of 2016, the top 4 chains in Nigeria owned less than like 2% of total volume. And some of the analysis that you sent, some of the homework that you sent indicated that your initial target geography sits on top of a $2 billion unserved diagnostics market, serving more than 250 million West Africans that have limited or no access to high quality, affordable diagnostic care. So yeah.
To add a little bit more context to that number, when a lot of the research people do on trying to figure out the size of the diagnostic market, it's always trying to evaluate current demand, right? There's a lot of non-consumption going on. And so when you think about the non-consumed market, that it's probably around 2 billion.
Yeah.
And part of it is that when you don't have diagnostics in a location, it's not that people will stop getting care. What happens is doctor treats according to clinical science, right? So the gap might be there, not being served, but people would do half is better than none, right?
Yeah.
And so the quality of that healthcare will be much poorer, but it will still happen. And sometimes the outcome for individual patients will be much, much worse.
Yeah.
And so that's what we see is that even though the market at 500 million, it's kind of small for Nigeria when you think about it.
Yeah.
A single player in Egypt, for example, does over 100 million in revenue. So when you think about Egypt is 90 million people, Nigeria is 230, 240 million people. So that number is much, much smaller. There's a lot of non-consumption.
Yeah.
And when you look at the non-consumed number, it's probably a higher number. It's around 2 billion, 3 billion market.
I would love you to give a practical example of that. Clinicians, when they don't have access to diagnostic data, treat by clinical science. Like, what does that
easy.
look
I
like?
grew up in a small town in Ikaria, Koko, in the States. When I was growing up, there was not all diagnostics was available in the town.
Yeah.
There's probably only a couple of X-ray machines. And so if you came in, for example, let's even use a lab procedure and you needed to do like a viral load for something that nobody could do, nobody had it, and the doctor know you cannot afford it, they will just treat you right there with something. Oh, here's an antibiotic, here's some antiviral. We think this is what you have, and you might have done something totally different. Or another example is what tends to happen when people have fever in Lagos, right? The first thing you do is you're going to take anti-malaria.
Yeah, malaria. Everything is malaria.
And it might not be malaria, right?
Yeah. But
you could have done the test, confirmed. And oftentimes it's not malaria. It might be something else. And that's why, oftentimes when we go to a new place, we pretty much have to, if it's a place where maybe we're the first diagnostic operations there,
Mm-hmm.
a lot of it would be first trying to educate the doctors around like, hey, this is available now. There's a lot more tests you could be doing now that you weren't doing before.
Yeah.
And when you also think about it, even in places where diagnostics used, there's some diagnostic capacity, there might be new type of testing coming out that will be better than the old good standard.
Yeah.
So for a classic example is say WIDA test for typhoid, where most of the world have moved on from using WIDA test to do typhoid. We have to be the one educating the doctors in those places because historically that's what they used.
Yeah.
But now, we have to educate them that, hey, you should probably be doing a stool MCS instead of WIDA. So what we do sometimes is if you request for the WIDA, we package it with the gold standard so that the doctors can start thinking about things differently. So it's important.
Yeah. And how do the doctors respond when you educate them like, hey, there's a better test available, or hey, there is testing now available? Do you find that they change clinical practice quickly, or it's more of a slow burn?
It's more of a slow burn. I think, and rightly so. I think that in healthcare, things move a lot more slower, because some of these things that people have been doing, even though it might not be optimal, has worked for them for a long time, and they've kind of like learned to they've gotten used to that risk.
Yeah.
Right.
Yeah.
So now you're telling them that, hey, there's a new way of doing this. That they have to like start thinking about the new risk. Like, is it lower? Is it higher? Whatever. So things are a lot more slower.
Yeah.
But eventually, people will change if all of the science points to the right things.
Yeah.
So yeah. But it's one of the the unspoken work you have to do. When you're in this sort of field.
Yeah. Yeah. So that is a very useful, like, on the ground tidbit. And when you mentioned about malaria, like, people just assume when you have a fever it's malaria. I was at a conference in November of last year, Society of Quality for Healthcare conference, and Professor Abayomi, the health commissioner for Lagos, mentioned that his team actually did an empirical study to really understand what exactly is the prevalence of this malaria that we say everybody has. And I have to go back and check my notes, but he mentioned that the majority of the cases wasn't actually malaria. So while we think any fever that comes up, you just assume, oh, I have a fever, I must be coming down with malaria, their data actually found that is actually, by and large, not always the case.
True. Yeah.
But we skip that step of, is this malaria? And we just go straight to the pharmacist and we're like, I need antimalarials.
And then if it doesn't work, the tricky thing about this is that there's probably around 15% of the time where you do it and it works because you actually have malaria.
Yeah.
And then that colors your thinking about it.
Yeah.
So that the next time you have something like this and you go and take antimalarial and it doesn't work, or you're getting worse, then you don't know what is going on, and then you rush to the clinic, and at that time you might be a much worse thing you're dealing with. Meanwhile, if you'd just gone to a proper clinic originally, gotten tested, confirmed your diagnosis, you will be in a much better place.
Yeah.
So it's kind of like those are the kind of health-seeking behaviors we still need to work on to change for our people. Yeah. So,
and I view diagnostics as the data engine of the entire healthcare industry. Like it tells us the disease profile of an entire country if you have consolidated diagnostics data. So I wonder, with this one anecdote of malaria, how much are we missing? Like, what is it? If it's not malaria, what are the things that are driving fever that we just don't have insight on, because we just assume it's malaria and we just treat anyway. And I think there is a case to be made for the I'm not, this is not profound. I'm not the first to make this case. I'm sure you have made this case, and you have in the pre-reads that you sent me, that data from the diagnostics industry has so much potential to inform literally everything else in the healthcare space.
I think diagnostics is one of the bedrocks of modern medicine. I think 70% of the time you're sick, your doctor will say, hey, you need to go get tested. And even if you're really sick and the doctors just start treating you, you also like, what's going on? You should send me somewhere, right?
Yeah.
And so that's one of the reasons why we focused on diagnostics. When we started the business, like you mentioned, we were just doing medical equipments generally.
Yeah.
But once we were in the process of pivoting, one of the reasons why we pivoted to diagnostics was that that subsector was so important, yet not a lot of people worked in it because obviously obvious reasons, capex heavy, and then a lot of like bigger companies were there, so and then its infrastructure is just so tough to build, so not many people get into it. So that's part of why we focus on that subsector. It's so important for modern medicine. And in every other country that the sector tends to have significant scale and have like one big player, but in Nigeria it's so fragmented, and so we saw the opportunity to consolidate the space, to integrate some of the fragmentation we saw in the marketplace.
And those are the exact things that we're going to kind of touch on. I also wanted to touch on, when we think about the fragmentation, I think one of the defining features of the organized diagnostics market over the past decade has been this kind of influx of international capital or acquisitions. So, for example, in 2017, Synlab, Europe's largest lab operator, acquired a majority stake in Pathcare Nigeria, then one of the country's largest private labs. They had like 6 labs, 21 collection points, etc. In 2019, France-based Soga Healthcare and Lancet Group of Labs established Soga Lancet Africa, this joint venture that then took over Clina Lancet. So now we have Clina Lancet, which is now officially known as Soga Lancet Nigeria. And so that brings the Lancet side, which is indigenous African operations, the Soga side, which is your kind of European. So we have all of these kind of large chains or large players in the diagnostics market that have brought in this influx of international capital. And I find that very interesting, and that's something that we're going to
we forgot to mention IDH acquiring Ecolab also.
Oh yes, Ecolab, owned by Integrated Diagnostics Holdings. That's a Egypt headquartered company. So there's a lot of international players
in the space.
And my view of MDaaS and Beacon Health is it's quite indigenous in the way it operates, in the way it thinks about where to expand, in the way it thinks about the demand gaps that it wants to plug. So that interplay I find very interesting, and we'll get into that. But I also wanted to touch, lastly, before we jump in, on an article I wrote recently where I spotlighted MDaaS.
Thank you.
So on TC Health, which is the parent company of The Cure, I wrote a piece called Oil Pipelines, Cell Towers, and Bottling Lines, what healthcare can learn from Africa's capital giants. And the argument I made in that article is not a necessarily new one, is that healthcare in Africa, especially in Nigeria, meets all the standard criteria for a capital-intensive industry, even when you think health tech, because you can't scale health tech with no infrastructure. So large investments in physical assets relative to your labor, high fixed costs, long payback period, high barriers to entry, like all of those encompass healthcare in Africa, especially in Nigeria. And we use MDaaS as the real world example for high barriers to entry in terms of the original equipment importation thesis that you kind of launched with ran into that wall the moment it met a infrastructure deficit market. And now you then had to pivot to actually building that infrastructure yourself. So I think there's a lot that we can learn about how we've scaled oil, how we've scaled telecoms, how we've scaled FCMB, like the food and beverage industry. We're able to get a bottle of Coke to the most remote village in the country. Why can't we get insulin? Why can't we get, anything else pretty much for healthcare? So some of the lessons that can be learned from those big capital giants that are capital intensive, if we were to just reframe and just say, okay, healthcare is part of these giants in terms of capital intensity. I'm curious your thoughts around that. And as you were kind of transitioning from, asset light to let's build brick and mortar ourselves?
Yeah, so I think that, there's obviously a lot of overlaps. I think what is slightly different in when you look at the telecoms industry is that, there was Nitel before the big guys came in, and Nitel was not doing well. But I think once the big MTNs of the world started coming in and people saw the potential, I think the flip was almost like overnight, right?
Yeah.
But it wasn't. It was something that happened over a period of time, and then all at once.
Yes.
I think with healthcare, probably the same thing might happen, but there's still very foundational things we need to fix in the healthcare sector. I think, and I think until we fix those things, we don't see that transformation. I think number one, for healthcare, people expect some parts of healthcare to be free. I think we've been socialized that way. And so the kind of big investments we need to transform the industry wouldn't happen except there's a payer. Not today, maybe tomorrow. That a proper payer for all of the services that infrastructure generates. And so I feel like that's a really big question. And right now, the government is definitely not the payer. The HMOs, most of them are not fully profitable. So they also cannot be the payer of those. And then the people too we live in a poor country. So individuals also cannot be the payers for that. And so that's the fundamental problem, that until we solve that problem, it could be that the way to solve that problem is that Nigeria just becomes a very prosperous country and everybody has a lot of money. And then we just say, okay, the payer is just the patients. And then we build infrastructure to serve them. And then everybody's happy. But yeah.
That's a very idealistic, optimistic picture. Yeah. But that's a very interesting framing. It's like whoever solves for that payer problem, I think unlocks a lot for everything else in the healthcare space.
And that's what we're trying to do. We're trying to build infrastructure for what people can afford today. But it's also like, it's hard.
But yeah, those were some of the context settings. So hopefully everyone listening up until this point has a good enough grasp of what the diagnostics market looks like for us to keep this conversation very stimulating. The core question that anchors all our discussions on The Cure is, what does revolutionizing the African healthcare business model look like? And specifically for today, we're going to be asking you what that revolution looks like for diagnostics, physical healthcare infrastructure, and everything else that once you build infrastructure has to build on top of that. But before we get into that wider question, I want to start with you. I would love for you to walk us through how you came to build MDaaS. What was the path from where you started to where you are today? Like, take us back to that class at MIT where they asked you to build a company that will serve 1 billion patients or 1 billion people, and how the idea of MDaaS kind of crystallized in that moment.
Yeah, so thanks for having me. It's great to be here. So for me, I always wanted to be an entrepreneur, and my journey at the time, I was in the US. I was working a tech job. I was a software engineer at the time. And I was working for a company that was at least 50,000 people. And I just knew that I wanted to live a life that was more impactful. That I didn't want to be a cog in a big wheel. I just wanted to. So, and that journey led me back to MIT because I felt like at the time tech wasn't as big in Nigeria as it is now. So I felt like, going to MIT would give me a lot of the skills that I needed to move back to Nigeria. I think I was living in Boston. It was extremely cold. And so I really wanted to come back home to Nigeria.
That's a motivating factor for sure.
So I started MIT, did this class, and the primary challenge of the class was, can you set up something that impacts 1 billion lives? And it doesn't have to be 1 billion lives today, but you should be able to see a way to do that. And for me, everybody in my family works in healthcare, right? My dad's a medical doctor. My brother is a medical doctor. My sister is a nurse. My other sister is a social worker, and their spouses, by the way. So we all work in healthcare. So even though I was an engineer, I, I just felt naturally drawn to solving a problem that I knew that my dad had, which was around equipment. How do you get access to good equipment? My dad owns a 30-40 bed hospital in Ikare, Akoko, Ondo State, where I grew up. And I knew that he had issues with getting good equipment for his hospital. So I felt like there's a lot of doctors like my dad, that if I could build something for them, then that was going to be, I will be able to impact as many people as possible. Given that not only am I impacting the doctors, but also their patients, right? And that's what we set out to do. And at the end of the class, the finals for the class was applying to a bunch of competitions and things like the MIT 100K and the rest. Unfortunately, we didn't win the MIT 100K. We didn't even go anywhere with that. But we won. We were chosen for this accelerator based in South Africa. That was led by Fred Swaneker at the time. And first, Swaneker is still one of my investors till today because of that. And because we got into that accelerator, that gave me the confidence to say, you know what? I don't know these guys from anywhere. They gave me $20,000 to do this accelerator and try to start this business. Then I cannot take their money and run away. I must actually do this. I must actually do what they told me to do. So, at the time I was still finishing up my studies. So I actually wrote my thesis at MIT on how do you bring capital equipment to Africa, and did a lot of research around it. Came to Nigeria, visited some of the big infrastructure businesses for tractor businesses in Nigeria and how they were doing it. So I had enough insights. And the name of the business is MDaaS. It stands for Medical Devices as a Service, because one of the key insights then is that we wanted to take that hard asset and make it into a service for folks. So instead of just buying equipment, you would say, let me lease it or rent it. So you had the option to buy if you can afford it. You also had the option to lease, do a lease or to rent the equipment. And so my first set of doctors, who are mostly my dad's friends, to be honest, they bought a bunch of equipment from us, like X-ray machines, digitizers, patient monitors, fetal monitors. We brought a bunch of equipment in and sold it to them. They wanted direct sales, but not everybody could pay upfront, so we had to do payment plan. And for some of those payment plan took 2 years to pay, and then after the initial set of customers we had, we've really struggled to get more equipment out, even though we had a lot of equipment in the warehouse. What we quickly realized was that the economics, the unit economics to make this equipment work in these hospitals oftentimes don't exist. And doctors will want an X-ray not because they have enough patients to justify the cost of the X-ray, but because they were going to be the only hospital and that had the X-ray, and their friend did not have the X-ray, right? So it was not a totally financial decision. To go for a certain machine or whatnot, and that's when we realized that we needed to change. Was that the fundamental economic model for those equipment to exist in those places don't exist. And a key example of that is, say, a X-ray machine costs, say, 30 million naira today, and a doctor wants it, right? And he only sees 2 X-ray patients a day or 3 X-ray patients a day. A lot of doctors will still buy it, right? If they have the money. Sometimes the money is coming from a different, maybe a side project they're doing, and and they will buy it and just do it, and the machine will be in their office or in their hospital getting underutilized. So we saw a lot of that happening, and that we knew, and that prevented us from being able to to get the equipment out. And then we also realized that there was still a need, because in Lagos, where a lot of our lease and rental businesses were, a lot of folks in Lagos loved that, because pretty much, you took care of all of the equipment for them, and they just pay you a flat fee every month and whatnot.
Yeah.
So the hospitals that we wanted to serve are like, hospitals like my dad, but the hospitals we ended up serving were the hospitals in Ikoyi and, the creme de la creme places, where we were just pretty much dashing them money by doing that model with them, because we just took a lot of their risk away from them. And there were never really enough of them to build a business at scale.
Yeah.
And because that scale has been something that we knew that if we couldn't build a business that could achieve significant scale, that it was a big no-no.
Yeah.
So when we realized that we couldn't do that with that model, we had to change something.
Yeah.
So
A lot of these points that you raise, I'm going to like break down and just dissect one by one, but I want to kind of follow up on a few things. The first one, you mentioned your dad has run a hospital in Nigeria for more than 3 decades.
Yeah, for 40 years now.
Yeah, okay, 4 decades. What did watching him practice teach you about everything that informed not just the original idea for MDaaS, but how you've evolved today? Like that experience of watching your dad run a hospital, what did it teach you that didn't become obvious until you kind of decided to go with MDaaS?
So, I was born in my dad's hospital, grew up literally in an hospital setting. When I was born, I think our apartment was upstairs, the hospital was downstairs. So it was one of those type of hospitals, right?
Yeah.
So I think just being around that environment, just, you see, my dad worked really, really hard. And and just being there, seeing how, it doesn't matter, what mood people are, he tries to make them have a better day by just meeting himself. And that's something that we internalize in our business now, where it doesn't really matter that, when people who are doing diagnostics are not coming there because they're having a swell day.
Yeah.
Right? So when people come to our facilities, we want to make sure that we make their day better. So that's something we've internalized.
Yeah.
And that's something my dad did time and time again. And also the work ethics of being a doctor. I think Nigerian doctors are one of the most hardworking professions. At least growing up, he would work himself. We had to beg him to retire. And so it's just, it shows that if you want to build something of note, you need to work for it. Nothing is given, so yeah.
Yeah. And then just going through your 3 co-founders who all bring different perspectives. Some have worked on the ground as well in Nigeria. Some have worked in Uganda, Malawi, in Ghana. What did each of you bring that the others didn't? So how does this mix of 4 co-founders make MDaaS possible, and how has it shaped the way MDaaS looks like today?
Yeah, that's a great question. I think my co-founders, I have a large founding team, 4 of us, right? And sometimes people are like, wow, that's so big. Is this such a huge team for what you're doing? But what people don't realize is that we run 4 different businesses in one. When you think about it, 4 or 5 even. So we still run the import-export, but that's how we still import a lot of our own equipment and supply. So even though we pivoted from that business, we still run it.
Yeah.
We run clinics. We run the operations that build clinics. We have a logistics firm, and we do tech. Right? So but what having this unique set of people have done for us is that we can contort ourselves to the team to run each of them. So, and with different combinations. So Okwa and I, we're both engineers. We still do on the equipment side.
Yeah.
And then in terms of like operations, people operations, Genevieve and I will work on that side. In terms of tech, it's Joe and I that work on that together. So we can really change the Lego to say, okay, these people, you do this part, I do this part, and do. And also because, this has been a long journey, and this is probably going to be a 20-year journey for us. Right? It also means that we're also like going through life at the same time. So we are having kids, getting married. Joe was my best man. I was Oppa's best man. In all of that. And, so we're also having kids now. It means that we can all fill in the gap for, like, so I recently had my second child.
Congrats.
And thank you. And my wife Genevieve, who is also my partner, was away for maternity for 6 months, for 5 months or thereabout. And we were able to fill in the gap while she was away and whatnot. So that's kind of like having that team does. And then we are also like really great. I think that what we do is really hard. And I think we are the best team doing that in Nigeria. And I'm not even trying to brag about that. In terms of being able to do the work at a really high level, given how hard it is, I think my team is the best at doing what we do.
Yeah, I love that. I've you usually see like one co-founder or two co-founder team, and it's usually like one CEO and one CTO who's more on the tech side. But I like this idea of a well-stacked founder team that can, like, it's almost like modulates, like,
exactly.
based on the needs of the business.
Yeah.
And on the personal side, can kind of hold down the fort while somebody's dealing with the ups and downs that come
life,
with life.
And that's really, and it also helps us have staying power, right? Where we don't get burnt out.
Yes.
If someone wants to take a step back because like they are tired, we can say that's fine. Go take a break while we do this. And so it's giving us this. I think that's one of our superpowers is the team, is the founding team, and it doesn't matter what problem we need to solve, we can always solve it. Also because running it now, the business is roughly around 400 people. Right. And so we've gone to from being a team of 4 people, 4 co-founders, to a team of 20 people, to a team of 50 people, to a team of 200 people, now to a team of 400. And we've been able to evolve because we can always, do that. So.
And one more personal question before we go into the technical questions of everything MDaaS. You co-founded MDaaS with your 3 co-founders. Genevieve is also your partner. What is it like building a company alongside your partner? Like, how have the two of you divided the work, like what you put in place at home, what you put in place at work? Like, how do you show up to work, and then how do you show up at home? Like, I'm very curious to know what that is like.
I think that, to be fair, I don't think it will work for everybody, but I think there's nobody else I would rather do this with than her. I think it's obviously hard to say, oh, work doesn't bleed into life doesn't bleed into work. So that's unrealistic, and that does happen. But we've been rocks for each other at different times for both the home life and for the work life. So I think it's not, obviously I meet a lot of people, and when they find out that I work with my wife, they'll be like, oh yeah, I would never do that. But for me, to hire someone, it would have been impossible for us at the time to hire someone with the technical know-how that she does have. Right. I always make a joke that, if you can hire them, just marry them.
Or do both.
Yeah. But she does the work at a really, really high level. So she's been away for maternity, and she recently got back, and even the step change in our production when she came back was like great to see. And I was like, yeah, thank God you're back. So that we can, do this, we can keep doing this together. So I'm just extremely lucky that I get to do life and work with my best friend and the person I love the
Aw.
most. So
I
yeah.
love that. Oh,
Yeah.
it's making me all mushy. But okay, now let's pivot into the pivot. So the pivot from importer to builder, where, as we mentioned, MDaaS started out in 2016 to import the equipment, but pivoted to building those centers. I think it's in a 2022 piece that you wrote, because I like to, when my guests write, I like to read what they write because it gives me kind of a peep into what you're thinking. In a 2022 piece you wrote, and I'm going to quote you here, you said, when we informed different health experts that we were pivoting from a medical equipment supplier to a diagnostic service provider, the feedback we got wasn't very positive. Building diagnostic centers is too capital intensive. You don't have enough experience. You won't be able to get VC investment for brick and mortar retail healthcare. Take us inside that decision to pivot. What you've already told us what you saw in the kind of importing equipment business model that led you to the point where you were like, okay, we might need to change our strategy here. But that moment where you moved to, let's make the decision to build our own centers, like that specific decision, like what was the gap between seeing it wasn't working and actually committing? What were you doing in that period? What was it like to make that decision? Where did you start? How did you move past the negative feedback? Like, just, I would love to understand that exact moment, the pivot itself.
Yeah, so typically it's a series of moments, right? Of things that happened that you obviously 2017 was one of our toughest year. Because when you, as an entrepreneur, when you come out of the gates, you're just running on vibes.
Yeah.
And we had customers, which was mostly my dad's friends. We served them, everybody was happy. But then the next set of customers was very difficult to find, because the products we had at the time did not fit. There was no solutions market fit for us, pretty much. And so it was, we were, I think in 2017 our revenue was maybe something like $2,000 throughout that year, after doing $100,000 the year before. So it was a very humbling experience.
Yeah.
And one of the things we quickly realized was like, you know what, we need to, whatever, if we wanted to keep doing this business, we need to have a thesis about what we're going to do, and really understand what is driving what's actually driving the decisions of people, of the doctors and whatnot. And once we realize that, they don't have the money, the doctors oftentimes don't have the money. Oftentimes, they owe folks a lot of money, because the customer base is also poor. Unfortunately, it meant that our initial model was wrong for what we're doing. We just knew it. And so what we decided to do is go from first principles. Like, at the time when we started, we wanted to do, like you said, asset light, where we rented equipment. It was the leasing equipment that we really wanted to do. We sold because people said, hey, I would rather just buy it. But the leasing equipment was what we felt like. If every hospital was just able to lease equipment instead of buy equipment, then everybody has the equipment they needed. But when you had all of the interest fees and everything, it didn't work for the doctors, and they were very vocal about that. So when that didn't work, we're like, okay, is it that the problem doesn't exist, or that there's no patient that needed the services? We actually saw a lot of people come to us to ask for quotes for our equipment steady, but they were not just buying because they didn't have the money. Right? So we decided to say, you know what, let's go to one of the places where we've been seeing a lot of demand for people coming to price and take a deep into the diagnostic market. At the time, we'd looked at all of the equipment people were interested in. Out of all of the equipment we were bringing in, and we saw that it was the diagnostic equipment that was in the most demand. So we wanted to investigate that sector. Okay, everybody that was coming to price equipment was coming to price X-ray machines, ultrasound machines. rather than, patient monitors and, other sort of medical equipment.
Yeah.
So that helped us focus on that subsector. And then we now we called up one of the people who have been coming every 3 months to price equipment to say, hey, the guy was based in Ibadan. And we said, hey, can we come to Ibadan and just take a look at the diagnostic centers around? Because the guy wanted to do a diagnostic center in Ibadan. So we said, hey, can we come to Ibadan and just take a look at the diagnostic sector in Ibadan? And when we did that, what we saw was so jarring to us that we felt like we could surely do better than this.
What did you see?
It was just we saw that, when we went to, I still remember going to one of the diagnostic centers and just nobody just attended to me. I went to make an inquiry and then sat down and nobody came back to me to and the environment did not look nice. It wasn't like great, but patients were there.
Yeah.
And the front desk officers, they just felt as if they were doing you a favor, So it was obvious. I'm like, I could surely do better than this if I have the equipment, which we did at the time.
Which you had, yeah, you had the
We
equipment.
We had the equipment at the time. I had the equipment, so I could surely do better than this. And so when our first location was actually in partnership with the guy, and then
that was your like 6-month pilot that broke even in 6 months.
Yes,
in Ibadan.
in Ibadan, yeah. So but then we realized the first day we opened the center, the guy did not show up, and we're looking for him, and we thought he got kidnapped, and they said, oh, he went to pray on the mountain for the new business for the first week, so he didn't show up. And then that's when we knew that partnership wasn't going to work out.
Yes.
And obviously the partnership did not work out, and he had to exit the business, and we
you just
took over.
Carried on. Yeah. Oh,
so that's what informed. It was a combination of us just realizing that our thesis, when you're in the US, writing thesis and when you're on the ground, it's two different things. What we saw on the ground did not measure up to, was so different than what our hypothesis in the US. So we needed to change that thesis, and we did change it.
Yeah. And talk to me about the feedback that you got from health experts at the time. You mentioned it was overwhelmingly negative, but you still have some investors, like you mentioned, that are still with you until today. So was there a single conversation, a mentor, an investor that gave you the, I don't want to say permission, but like kind of motivated you, like you can do this, and here I will back you up in doing this?
So I think by and large, most of the people in the healthcare space just felt like we were going on a fool's errand, to be candid.
Yeah.
Right. Because when we were just a student team, like, right, we just barely out of school trying to do this. And then a lot of people that did the work, like, had money from the big foundations to set up something. And then when the money ran out, they kind of like went ahead and did something else. And people just felt that infrastructure work should be government work, like that, it's capex in. And I think that, to be fair, they're right. But for me, I have a quote I tell my team, is that the job determines the job. If the job is infrastructure, then that's what we would do.
Yeah.
Right? It's not like, and you can't shortcut it. That's why, when I see folks from the digital health space trying to move mountains, but then they rely on that infrastructure, I'm like, you don't even control your own destiny.
Yeah.
Right? So you cannot, it's always gonna be tough for you. Right? So for us, from first principles, we asked ourselves, what the people want the most is access to good quality care close to home.
Yeah.
Right? Close to home. That is affordable, that is quality, and that that they feel seen. That's what people, just from a basic first principle point of view. So doing anything less than that won't help them hit those notes wouldn't have worked regardless.
Yeah.
And so when people told us no, we just said, you know what, we would we would just keep going. We were lucky enough to get a few. We did the thing where young entrepreneurs do, where we won a lot of grants from this competition and that competition and this competition and that competition. And we got a grant from this foundation that actually Genevieve used to work with. And that was the funding that we used to do the first location.
Okay.
And when the numbers came out, by month 3 or month 4, we were seeing 400 patients a month.
Wow.
Right? So that was like really great signal. Meanwhile, in our old business, we spent 2 years and we had 5 clients. And this new business, in like 3 months, we had 400 people coming to our location because it was in Ibadan. So, and it was in Ring Road, Ibadan. In fact, that location now is our smallest location. Unfortunately, because we could have taken the old building, but we didn't know we were going to be successful. So we edged our bet. We took only the ground floor.
Yeah.
So we've had to open more locations in Ibadan now because that location is way too small for what we needed. And because number one, customer service and all of these things, we put our patients first.
Yeah.
And so a lot of these things now are the foundational principle with which we run the business. We have really great ambient centers, and then we do really amazing turnaround times, and we also make sure that we're always, the doctors trust us. We give great results, and they trust us because of that. And we're always like working with them with diagnosis, right? So before you know it, we kind of like just took off in terms of, and in fact, after we did our center, all of the centers around us that looked very shitty at the time I was going, everybody went to kit up their centers after that, right? Because we took so much of their own clientele away, and so everybody went to kind of like redid their center pretty much because of us at the time. So
impact.
So, but once we got that, we got the numbers. One thing is that we started applying for like tech stores. And we were able to get into tech stores. And then Kola, who is also a great friend right now, of VP Ventures Platform, invested in us also about the same time. And that gave us like now that validation that we needed to say, okay, maybe we're onto something here. This is just one location. Maybe we can do a second location. Maybe we can do a third location. And so that's how that happened.
So I'm curious, when you then, after the pivot and you saw the results from your first center and you went out to Techstars, you went out to Kola, what did your pitch deck look like at that point? Because the story of your company was 2016, we did really great. We started this company 2017, then we pivoted, and then we had this really successful center in Ibadan, and now we want to do more. What was in that pitch deck, and what did investors lock into? Like when they locked in, what were they locking
I'll send you
into?
that pitch deck.
Yeah, I would love to. I would have loved to see that. Yeah.
So this, funny enough, I looked at our old pitch deck recently, and the thesis of that pitch deck and our current pitch deck is still the same, pretty much. It's still like healthcare infrastructure for the masses.
Yeah.
And at the time, we said the thesis was that there's a lot of historically, diagnostics was built, or healthcare in Africa generally is really built around treating infectious diseases. But now you have this double burden of diseases with NCDs coming through.
Yeah.
And NCDs require capital intensive diagnostics to do.
Yeah.
And someone has to do it. And so this is not a sub story about, poor Africans. This is a massive market opportunity to build the infrastructure to help support healthcare systems across Africa with diagnostics.
Yeah.
And so that's the thesis that when I listen to my Texas pitch deck demo day, and it's still exactly how we pitch the business today. Is that there's a massive opportunity to make sure that health systems across Africa have access to great diagnostics.
Yeah.
And that's still true today. That was true back then. And right now, what's different is now, before I was saying that aspire to perspire. In the future, you see the snack and say, here are my numbers over the past 10 years. See for yourself. I wasn't, at that time, you need to have a little bit of faith.
Yeah.
But right now, you don't really need to have faith anymore. You can just see the numbers.
Yeah.
And then,
you can say it wasn't a bluff.
Yeah, it wasn't. But I think the people because I don't know, people are cynical, rightly so, because there's a lot of charlatans out there. When we tell people stuff about like we really want to build, like when I told teams, investors that, oh, I actually want to build like 20 locations like in the next 3 years, 2 to 3 years, we were like, oh, it's not possible. It's just like now we have 25 locations, right? It's possible. It's just about solving what are the barriers you have, which is like operational capacity to build those centers. Two is that does the market for those centers exist? Very important.
Yeah.
And the answer is a yes to the market question. And for the operational capacity, if we don't have it today, it's something we can develop.
Yeah.
And that's what we've developed over the past, So when we did the first location, I think we waited to 2019 to do our second location.
Okay.
So we took all of the lessons we learned in the first one, because in the first location we employed a lot of people who'd worked in diagnostics before. So you had to deal with a lot of people's bad behavior to kind of like
course
correct. But in the second location, we decided that everybody there could, is someone that has not really worked in a typical diagnostic center before, so that we can teach them our own playbook, which is what we did.
MDaaS way.
Yeah, and so we've kind of like iterated on that now. So right now we have a proper playbook for our centers, how we set them up, how we operate them, and how we do everything. So yeah.
Interesting. And when we think about the scaling of that brick and mortar, so we've talked through your first center. We're still in part one of your kind of company thesis. By 2018 you had done one center. By 2019 you had done your second center. By 2022 you had 15, right? Yeah. And then today you have 25, 26 company-owned centers, 40 affiliate clinics across 15 states. You also have a center in Cameroon, so you've expanded to another country. And a footprint of that scale requires quite a lot of operational discipline, and especially in an environment that doesn't make any of this easy. So I'm curious, what does it actually take to keep this network running every day across so many cities and so many states? Like, walk us through the operational reality of MDaaS Beacon Health on a day-to-day basis.
Yeah, so that's a great question. Obviously, managing all of that is a lot of work, but this is where technology can help. I think that when people think about the role of tech in healthcare, a lot of people want you to build tech that you can sell to people or customers can pay for. I think oftentimes in healthcare, what I've seen mostly is that tech can help you optimize, help you run things better, faster, in a more organized way. But you might not be able to. Nobody wants to pay for your tech.
Yeah.
Like, because we built a lot of the tech that runs our centers, and we do build a lot of tech. I'm a software engineer by training.
Yeah.
We don't sell it to anybody. We just use it for operations, right? We don't sell it to anybody. So, for example, our patients have a platform they can go to check their results and track everything there. Our HMO partners have a portal they can go to track everybody they're sending to our facilities.
Yeah.
Our centers have technology that runs it, that forces them to work in a specific way.
Yeah.
And our results, if you see a result from Beacon Out from, say, Lagos, and see a result from Beacon Out from Offa, looks exactly the same. And if you go to a Lagos facility or an Offa facility, they look also pretty much the same. They tend to have the same equipment.
Yeah.
It's like really standardization and then using tech to enforce workflow, so that your patients go there, this is what they do, they go here, this is what they do, then they go here, this is what they do, and then they wait a little bit, and then they get the results on their phones, or they come back to pick up a physical copy of the results, whatever their preferences. The tech forces people to do that way. So I think what has helped us is the ability to use tech to standardize and run in a specific way.
Yeah.
If you take someone who has worked in our center in, say, Lagos and put them in a different center, they would just
they'll just
they
go
will
for
just
it.
keep going.
Yeah.
Like they're not doing anything different.
Mm.
And oftentimes even when we do a new location, we
Mm.
like to like seed one of our old folks from a existing center in a new facility to kind of like ensure that we maintain that continuity
Yeah,
and stuff. But it's not just about the tech. Also, it's also about the operational processes and how you run your organization. So that's also very important. And so we're lucky enough that we've been able to do that. And obviously, it's not, there will be time where we fall short, but like overall we've been great at that.
Yeah.
I always tell my team this to encourage them. I tell them that anybody can do 500 patients in a month, and you can use paper for that. But right now we do between 15 to 20,000 patients a month, and so not many people in Nigeria, even the big shot folks, can really handle 20,000 patients a month, and there won't be any issues with it. And that's what my team does routinely every month in, month out. So it's quite impressive.
Yeah. And another aspect about your operational, the way that you run your operations is this 5-tier location framework that you use to classify different markets, which I found very interesting in my homework. When I was reading up on it, you have your tier 1 metropolitan cities, which ties into what you had mentioned even in the beginning, where you see that you tend to see a lot of diagnostic infrastructure concentrate around wealthy urban areas. So you have your tier 1 metropolitan cities like Lagos, Abuja, Kano, Port Harcourt, all the way down to tier 5, where it's more rural communities. And the strategy that MDaaS takes anchors to your tier 2. So your tier 2 is like your state capitals or your major commercial hubs like Ibadan, Ilorin, Osogbo. And that is where you anchor your strategy, because the idea for MDaaS is this kind of mass market. Like, where does the demand sit? Especially, and I love that you brought that up, the unconsumed demand and how do we get there? And a lot of the times it is in these tier 2 cities first. Walk us through how that tiering framework actually came about. Like, how did you develop it? What went into the thinking behind the framework, and how does it actually play out in practice? Because I see that in that pre-read that you had sent me, there's a way that you go through a very structured process before you think about expanding into a new location based on this framework. So I'd love you to just bring us along into that thinking process.
Yeah. So I always tell folks that I know I'm mad, but there's a method to my madness.
Yeah, there's a method.
There's a method to it, right? I think we started in a tier 2 location, and we saw how quickly we were able to get to market fit because we were solving a particular problem for the community. In the end, anytime we put a diagnostic center in a place, we're solving a problem for that health systems. We're truly like a health systems innovation.
Yeah.
Right? Because in the end, most of our patients will still come from doctors.
Yeah.
Doctors that could have, if they had the money, would have bought their own equipment, but because they don't have the money, they don't have equipment. So we are pretty much their centralized diagnostic department for all of the small, medium-sized hospitals across that community.
Yeah.
So one of the things we want to ensure at the beginning when we did this is like, where is the demand? It was easy to say Lagos, that's where all of the people were, but in Lagos, number one, I didn't grow up in Lagos. I grew up in a small town in Ondo State, right? So at the time, I was not really passionate about doing another urban, just my soul was not just
Another
there.
thing in Lagos. Yeah.
So, but doing it in Madan, seeing that trajectory that we had, kind of made me a lot more curious about like where else in the country can we go to and have similar trajectory that is not Lagos. So our second location was in Ilorin, right? And our trajectory in learning was even faster than Ibadan.
Yeah.
Right? And so we started understanding to say, okay, what are the why are we successful?
Yeah.
Not just saying, oh, we're successful, great. It's like, why? And we saw that we're solving a particular problem for the people, for the health system. And so at that point, it now became, where else can we go to, right? So the next one after that was Ofa.
Yeah.
Oh, sorry, was Oshogbo. That was the third one. And Oshogbo was interesting because we had a totally different, we're not in a major part of the town at all, right? So it took us a little bit of time to ramp up there, and then COVID hit, right? And so, but one thing we quickly started realizing is now, what two things are important? The city we go to are important, and the locations within the cities are also important.
Yeah.
That's one thing we learned there. So at some point, and then we eventually came back to did one center in Lagos, and then we realized that Lagos was actually difficult, was competitive, because Lagos is the HMO and corporate market.
Yeah.
And obviously the big guys are kind of like, it's very competitive with Synlab, Saber Lancet competing, Afri Global, Macure, and the rest competing for the same parts of the pie. So we realized that, you know what, it's great to be in Lagos and all, but the biggest place where we can have the most impact, and impact is something that is important to us.
Yeah.
It's going to be in, places where we can be the painkillers instead of the multivitamins.
I like that.
So we want to become, so our goal internally when we go to new places, that we want to become an utility in those places where without us, like with us, they've been there, they just need us because we're so ingrained into their healthcare system.
Yeah.
And the big test for this came during COVID, where, at some point people were home and people were worried at the time that, we're going to lose our customer base and whatnot. But the business actually grew. Like, even without COVID revenues, we didn't really do a lot of the COVID molecular lab. We did our molecular lab after the fact.
Yeah.
But we didn't book a lot of like molecular lab revenue, but our main business grew a lot during that period, which, because we were the places that was the most reliable to get diagnosis being done in these communities.
Yeah.
So then, after a few centers, we said, where else can we go to? Can we try a smaller town to see if the model still works? So we tried Offa. Offa, I don't know if you've been to Offa recently. It's a big commercial town, historical town, but it's very dusty. But there's a lot of people there, and a lot of universities now there, higher institutions there now. And we were the first diagnostic center in Offa.
Ever.
Yeah. And the way the business took off there was amazing. So we're like, wow, the business works in like the state capital, but it's working in an even smaller town. So that expands our total addressable market. And so, we've obviously did more centers. The tier 2 are still key to our, because we're trying to expand our distribution. We can talk about distribution later.
Yeah.
But last year we decided to test even smaller than Offa. So we test our most remote co-location, Share, in 2 hours away from Ilorin. It's I've never been there. Probably will never go there. It's really remote.
Yeah.
It's heart of the beating parts, right?
Yeah.
And the model also still works there. So now we realize that it's a massive market.
Yeah.
The market for diagnostics in Nigeria is massive.
Yeah.
But the problem is going to be, how do you scale like this infrastructure to many places as possible? One key caveat in those places is that the revenue potential, which we also look at in those places, might be slightly lower, right, than the revenue potential in like a tier 2 or tier 1 location.
Yeah.
But you're going to get profitable much, much quicker in those places because, the need is so great there.
Yeah.
And so everybody that is in that town that used to travel 2 hours before will stop traveling. So in Offa, for example, one of the reasons why we did Offa at the time was that every week we're seeing between 15 to 20 people come to our facility from Offa in Ilorin, which is about 90 minutes away, right? And we're like, if we're seeing 20 people coming to us, that means all the diagnosis center in Ilorin are also seeing like 10 to 15 people come to them also.
Yeah.
Right? So that let us know that there's enough people in Offa to justify, having a diagnosis center in Offa.
Yeah.
And now we see maybe 40 to 50 people per day in Offa.
Wow.
So that's how that model came to being. And then this year we said, okay, let's formalize the requirements, because now we actually want to expand across the country.
Yeah.
We at scale will probably have at least 100 facilities across the board. So we wanted to actually just put it down so that as we think about new locations, it won't be about like, oh, we don't want to do this now. As long as you're on our list, if we can find a property there, we will just do it, and we have the money, we'll just do it. We don't think about, because some centers will take 9 months to break even. Some centers will take 2 years. But now we're more open to doing all kinds of centers, just knowing that the distribution is the goal.
Yeah.
So yeah.
I have so many follow-ups. I have two main follow-ups, and I'm trying to decide if I ask both of them or if I ask one or
Go
the
for
other.
it.
So I'll ask both, and then you tell me where you want to go. My first follow-up question is this idea of how you've expanded and your tiering framework, almost decentralizing Lagos, if I may say. What do you think other innovators in healthcare, health tech in Nigeria can learn from that type of model? Because I think a lot of people operate from a Lagos first mentality. And then if it works in Lagos, we expand elsewhere. But you flipped the script and you were like, it works somewhere else. Let's see if it works in Lagos. So that's one of my follow-up questions. What can
I can just take that.
Yeah.
So I think that when it's because this is one of the questions that actually came up when we were discussing, when we were discussing actually the Ibadan location. Should we do Ibadan or should we do Lagos?
Yeah.
And one of the things I just said was, is that like Lagos is just 10% of the population of Nigeria. Lagos is not Nigeria. There's higher incomes here compared to the rest of the country. And I don't know if you've been to a general hospital in Lagos compared to a general hospital outside Lagos, like deep in the country. It's light and day. It's like it's like I feel like Lagos people sometimes they are spoiled for choice, but they don't even know it.
Yeah.
Like compared to the rest of the country, right? So for us, it was like, Nigeria is 220, 230 million people, and 20 to 30 million of those people live around Lagos.
Yeah.
The bulk of the price is actually outside Lagos.
Yeah.
But when I've seen folks who have scaled Diagnostics even, I see that everybody either have a Lagos strategy or a Abuja strategy.
Yeah.
Right? And I think the reason why they're able to scale past like we have done is because once you get used to that, the things that make you successful here would actively work against you in those places.
Yeah.
Right? The kind of things you do there that makes you in Lagos, that makes you successful. When you go to those places, you realize that, oh my God, this is so different, and I need to be. So I think it's important.
Yeah.
And yeah, so that's my point. And I always advise my edtech friends, which we share together, that Lagos is not Nigeria. Like oftentimes, Lagos, you are better off piloting outside Lagos.
Yeah.
And if if it doesn't work, you can try in Lagos. So if it works, you can come to Lagos or keep staying where there's so many places you can go to across the country and be successful.
Yeah. And then my second follow-up question was about the scale of your expansion. You mentioned, if you're on our list and we have a property there, then
and I have the money.
And you have the money, yeah. The very, very important, requirement. But talk us through the operational side. Maybe even like we say you're building brick and mortar. Are you putting the bricks down, or are you seeing the bricks and
we listen it? We listen it.
Yeah.
We listen it, but we still have to do our centers look quite similar, right, across the country. So we have template ways of how we design our centers. So we literally have a brand book for it.
Okay.
Where if you see this sort of building, this is the kind of center you will do. If you see this sort of building, this is the kind of layout you have. If you see this sort of, we have all of that now, right? So So, but the idea is because for us, once we decide to do a center and we find a property to do it, in 3 months, we want that center to be operational.
Yeah.
Right. So it's about how do we get there quickly.
Yeah.
If you're building from ground up, laying bricks and bricks, it takes you 2 years or a year at least. But if you can just lease a space, we know how much space we need. You can go in, do our thing. In 6 months, we're operational. In 3 to 6 months, we're operational.
Yeah.
In another 6 months, we've broken even.
Yeah.
And we're on to the next center.
Yeah. This is gonna sound really strange, but it just came up in my mind. This is like a McDonald's model. You know how in the US there's like 1,000 McDonald's locations, and they come in different shapes and sizes, but you know it's a McDonald's. Yes. Even when McDonald's, because they've tried to revamp to be looking more like modern and whatever, but every McDonald's location has the McDonald's
exactly.
look.
That's what it is. Pretty much, it's like retail, and even we share a lot of similarities in the sort of locations we want. With retail, really, we want to be on the main road, a lot of traffic, hopefully around where other hospitals are that we will target for our referrers.
Yeah.
And so it's like really standardizing, or de-risking, or what is de-risking that investment into that place by picking a great location and making sure that you have the high balls to see your operations and whatnot.
Yeah, interesting. And so one more piece on part 1 before we go to part 2 and 3. In November 2024, you opened Beacon Health Pasture Healthcare in Douala, Cameroon. I read a tech cabal article that reported at the time that the move was partly a hedge against the naira volatility by giving MDaaS exposure to the Central African CFA franc. So for our listeners that may be unfamiliar with the term, the CFA franc is like the currency used in Cameroon and a bunch of other francophone countries, African countries, and it's permanently fixed to the euro at a rate that doesn't move. And that fixed link to the euro means a business earning in the CFA franc effectively earns in a stable, hard currency, while the naira has fallen from like 360 to well over 1,500 against the dollar in like the past 3 years. Talk us through the decision to expand into Cameroon. Was it, as Tech Cabal reported, a hedge against the naira, or was there something you saw specifically in Douala in Cameroon that felt like there was a demand that you needed to fill?
No, I think it was mostly like a hedge. Obviously, that's not the entire decisions. The idea is that we knew that we wanted to scale past Nigeria.
Yeah.
Right. We always have that, and we still do want to. But at the time, the currency fell from, I think, 400 to 780, and then in a few months we went from 780 to, I think, 1.5 at the time, and now it's dropped to 1.350. And so it was just a lot of things going on, and we felt like if there was any time to go set up a different place, so that if the currency keep going up and up, there's also like another place that we can potentially grow in. So we actually visited a few African countries. We were in Ivory Coast, we were in Togo, we were in Ghana, and Cameroon felt very familiar. And it's not really as developed as Nigeria, as Lagos, but we also felt like there was a need there.
Yeah.
And so we were able to set up quickly there. And then the regulatory, one thing about healthcare is regulatory is huge in healthcare. And so we were able to figure out the regulatory. It still took us quite a bit of time, to be honest, but we were able to figure out it eventually in a way that would have been much, 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 much difficult in, say, a Ivory Coast or, say, a Senegal.
Yeah.
So because we felt like, we had the contacts on the ground to help us do that, that helped us make that decision. But to be honest, things are hard everywhere too. So right now, because we kind of like, with the stabilization of everything now in Nigeria, we focus a lot of our good efforts in Nigeria right now. but I think we would still love to go back there and scale the same way we scaled in Nigeria.
Yeah.
But right now we're back to kind of like building mostly in Nigeria, because we felt like the distribution, we're still at subscale levels. And not just us, every diagnostic provider in Nigeria is at subscale levels.
Yeah. Yeah.
And we feel like to win the market in Nigeria, you need to be at scale.
Yeah.
And so what scale look for us is at least, 100 locations, and maybe if you want to do maybe 60 locations. But for me, because I set high standard to myself, what skills look like to me in Nigeria is 100 locations. And because we have the people, we have the demand, but we historically we just not had the capital to scale this sort of business this way. And so we want to be the first to get to 100 locations. And so that now we mostly focused back here. And why the business kind of like just run in Cameroon kind of run by itself. And So but the tech that runs it, our center in Cameroon looks exactly like our center in
Still
Lagos.
that brand identity.
The software they use, we translated our software to French.
Yeah.
And so that they still use the same software, which is why we know that like our technology stack is so powerful that eventually it might be a product that we can use to partner with other people in other countries where and that's probably how we'll think about scaling in other African countries, where we go in, we have a on-the-ground partner that is in the clinical space already. We will bring in the technology know-how, maybe some of the financing to do it, and then to be a joint partnership. So that's how we'll probably see Pan-African expansion going forward. But in Cameroon, we actually own it. We didn't do like a JV in that way.
Yeah, interesting. We've touched on part 1 of MDaaS strategy, which is building the physical rails, the physical infrastructure, the centers. Part 2 is the technology that turns those rails into more of a coordinated network. In your words, diagnostics sit at the nexus of healthcare delivery. So an operator at this scale is actually quite uniquely positioned to address the digital fragmentation that runs through almost every patient journey in Nigeria. You go to one center, they're using one health tech platform. Then you go to another center, they're using something else. Once the centers were running, MDaaS started building software and products and even partnerships around them. So like we've already discussed, some of it was operational. The tools needed to actually run a clinic well, like within MDaaS. Some of it was commercial, so products that let companies and HMOs use the network. Some of it was logistical. Some of it emerged because maybe some of the partners on the ground or your founder team and your internal team asked for it. So we have things like Beacon OS. We have Olework.
Olework, yeah.
Olework.
It's
I just wanted to
funny,
make sure I pronounce that well.
It's Olework.
You have Beam. You have Medverse, which is more on the logistics side.
Medverse is the logistics.
Yeah, and then you have Lucent AI
And
Hazel
Easy
AI.
Yeah.
Am I missing something? Sentinel X.
Something that's a patient portal.
Yes. So I want you to talk us through.
So I know it sounds a lot of confusing, but really what we have is like we built like an operating system called Beacon OS.
Okay.
It's a single backend that every other application sits on. So when this is Beacon OS, then you have the center application called Olework.
Okay.
Sits on top of it. And so when your result is ready, we also have another application called Sentinel X, where that's where you get your result. So your result is ready, the center application, they fill in your results, send it to Beacon OS, it sits there, but the center application has access to your results, so they can print it for you, but you can also have a different software
on the patient
application
side,
Sentinel X to access your results. But if you're, say, an HMO customer, or a corporate customer, coming from a corporate, and for some reason maybe the HR department needs to access your results too, then there's a portal for the corporate and HMOs to also access the result of everybody they send to us. If you know, so it's easy. And then we have Lucent AI because we do a lot of reporting.
Yeah.
It's a central reporting portal where a lot of our doctors, reporting doctors sit in Lagos actually.
Yeah.
But they report across the network. So every annual screening that you do with us is reported by a doctor sitting in Lagos. So we also built a portal for them to be able to pull in all of the results from all of the all centers and report from one single point. So it's really, really fast.
Yeah.
Or if you say like a radiologist needs to read your reports, you know, the center send it to the radiologist writes a report for you and send it back. They use Lucent AI to do that. And Azu AI is our primary care application we're building for primary care doctors because we're doing R&D on a primary care product right now. And so that's the software to run that. A way to make it faster to do primary care.
Yeah.
So we've built all of this software as we need.
Yeah.
You know, as you know, something becomes a pain point, we'll build something to make it faster. And I think it's so important to be able to do that because oftentimes with businesses like ours, there's really no bespoke software that really matches your workflows.
Yeah.
So you have to look at your workflows and build for it, and which is what we've done. That it was going to be really difficult for us to say go to get like a off the shelf EMR system to use because it wouldn't have some of the things we do or all we need to do. And it won't really work with our workflow. So the fact that we built ours make it life much, much easier for us. And we've built in such a way that if we need to talk to folks, so we can give APIs to folks. So if you have an EMR and you want to be able to send results to me or send requests to me, you can do that. So and we have a few digital health businesses who have already connected their own systems with our own system, so they can make a request digitally to our systems and they can get their results digitally too. And this is something we can provide for any HMO that wants it. In fact, we've pitched this to so many HMOs, but nobody wants to do integrations. You know, people want to work the old way. We think the integrations is faster. But yeah.
Interesting. And I see your background as a software engineer playing a big role here. I had a question about, as we move from part 1, part 2, part 3, and just the big picture, where do you see the tech playing a role? Right now, it's a lot to support your internal operations. But like you said, you've started shipping to even external partners. Where do you see that evolving? And what do you think the inflection point is to reach that scale, especially on the tech side? Because you just mentioned HMOs are hard to convince to take on some new tech. What do you think it would take to convince them? And where does that play a role?
Yeah, so for me, I think that you can convince them to do tech if they're not going to make money off of the tech. If it's going to be a cost center for them. I think that's the big thing with technology in healthcare. Most people that try to sell tech to doctors or hospital systems or HMOs, most of their techs are going to be cost centers, right? If you don't have a tech that is like can actively generate revenue for folks, then nobody would buy it because the margins in healthcare for us is thin already as is. So the little margins you have, someone wants to be collecting part of it every month from you. In the name of tech, when paper works. The other thing about tech in healthcare is that like people, particularly, you know, there was a time where every Tom, Dick, and Harry was building an EMR. Like in the 50s and 60s, there were great hospital systems running on paper. In Europe, in the US, whatnot. And it worked fine. You know. So paper is a tool, but an EMR is also a tool, right? And so you think about it that way. So for me, we will keep growing our tech stack. If people want to integrate, great. If people don't want to integrate with it, also I'm okay with it because it's providing a lot of benefit for me. There's no way I would be able to run a 100 facility network without tech,
Mm-hmm.
right? I wouldn't be able to run a 200 facility network without tech.
Yeah.
So IDH, who runs one of the biggest networks in Africa,
Mm-hmm.
have a network of, I think, 700 clinics, right? They can't run that without tech,
Yeah.
right?
Yeah.
So that's the role of tech, is to help you synthesize your operation. I
Mm.
think the big thing I see with the tech when I look to the future is the ability to generate insights from the data that we have,
Yeah.
because we hold a lot of data already, a
Mm-hmm.
lot of useful data, that I feel like we should be writing more papers, to be honest,
Yeah.
from what we're saying,
Mm-hmm.
because we can track diseases across different locations,
Yeah.
already today. Like anytime, like the time where they had like the cholera outbreak,
Mm-hmm.
we're able to track that in our data sets to know, okay, where are people requesting stool MCS,
Yeah.
because that's one of the primary ways to diagnose that. And we see that there was an uptick in the key areas in the country that had the outbreak.
Yeah.
Right. So there's a lot we could do with the data, and there's a lot of partnership we'll probably need to have with, like, clinical research organizations, maybe in helping them recruit folks for clinical trials.
Yeah.
I think that's the important part of the work that we should be doing, that we're currently not doing right now.
Yeah.
But I think we are still, like, we're still cooking.
Yeah.
So
Yeah.
I think that those are the kind of opportunities that having the data gets you to having in the future. It's like we are buying options on this for the future.
Yeah.
So yeah.
Interesting, because I feel like a lot of people talk about wanting to do more clinical trials in Africa, because I think it's like the number is like less than 1% or 2 to 3% of clinical trials are actually done on this continent.
Yeah.
Yet we use all these drugs that haven't really been studied in our populations.
Yeah.
So there's a lot of momentum right now, in tandem with the momentum for local manufacturing, to do more clinical trials. And people are always saying, well, we need more centers of excellence. And yes, you can get the centers of excellence down, but
You also need a way
you
to
need
recruit
to recruit people, and you
Yeah.
need the diagnostics. You
You need to
need,
be able to recruit people.
like, if
That's
you've
such a
read an
bottleneck.
inclusion criteria for, especially with precision medicine
Yes.
trials, cancer, with all the biomarker testing, if you read the list of inclusion criteria, half of them require diagnostic tests.
Yeah, absolutely.
Yeah.
And that's something that we are uniquely positioned to do because of the volumes that we see.
Yeah. Yeah.
So yeah, it's I think for us it's an opportunity for the future for sure. But we know that there's a few folks working on this problem already.
Yeah.
So it's one part of that ecosystem that we cannot just go into ourselves. We need actually a partnership on the other side.
Yeah. And partnerships are clearly a big part of this story. I think I'm curious to hear what your overall partnership philosophy is, because I look across some of the partnerships that I saw when I was researching MDaaS, like Clafia, 8 Medical, Health Tracker, and there's others on your network. How did some of these important partnerships come about, and what is your philosophy when it comes to partnerships?
Yeah, I have a very simple philosophy when it comes to partnership. 1 + 1 must be equal to 3. Right? So you must create value.
Yeah.
And you must be able to capture value. Oftentimes with partnership, when value is not being created, obviously, then the partnership just dies a natural death, because the two partners will just rather be doing their daily day-to-day job rather than working together. So for me with partnership is that I must see that we can coming together helps us create a clear value, right, that can be captured and shared between the both partners in an equitable way.
Yeah.
I think healthcare partnership are hard. We've done a few partnerships that have worked out, done a few that's not worked out. Oftentimes about alignment. Is this person looking at things the way I'm looking at? Is this person willing to build for the future? Oftentimes people want to share, they want to kill the goose that lays the golden egg before it's,
Yeah.
But sometimes, we're 10 years in the game, like we are very patient.
Yeah.
And for me, I'm one of those people who I told myself that I'm not one of the lucky ones. I'm one of the ones that need to work hard for things to happen to them, right? So for me, and I'm willing to do the work. And so I know that there's no silver bullet anywhere.
Yeah.
That we need to be patient. In healthcare, you actually need to be patient. So if we find partners who have the same mentality about this, I'm always excited to work with them.
Yeah. And we're both part of a Digital Health Nigeria community, founded by Dr. Neto and Ayobami, and I believe there's another founder of DHN. But it's more than just a massive WhatsApp community, but it is a massive WhatsApp community. There's a lot of, I was discussing with Neto, like really lofty goals of what we can do as a community. I'm curious, within the because there's a lot of founders in the community, are there any adjacent companies that you would like to partner with, or do you see any peers that are doing things that you would like to kind of align with as you think about building MDaaS?
Yeah.
Any shout outs, basically?
Yeah. For example, I work with Neto really closely and actually on multiple projects. There's a few folks where we've done a lot of partnership with, Earth Tracker.
Yeah.
Even though we're competitors in some of the space, we also work together in some other space. So we work really closely with Earth Tracker, It's Medical. Yeah. So we work. In fact, I feel like for a good chunk of folks there, we are their diagnostic backend when they need it, right? Also because I'm accessible, right? In a way that they can just give Synlab a call, or they can just call me out of randomly and make sure that people get what they need from us.
Yeah.
So I think that it's good to have communities like that, to be honest, because iron sharpeneth iron. That's what they say, right? So there are folks that I maybe we're not in partnership with, but we have a lot of conversations together about the future. So Simpa is one of them, Dr. Simpa, where he's been building in the space for almost 20 years now.
Yeah.
And now I'm 10 years in the game. And so we would have we talk about our thesis, and we kind of like try to see which ideas can we improve our ideas together.
Yeah.
And so those kind of conversations, I find them priceless because they help me. For me, I'm not just building as the wind blows.
Yeah.
I'm building a specific thesis.
Yeah.
That means I need to keep revisiting it to make sure that testing it to make sure that it's the right thesis.
Yeah.
And that sort of conversations help me test it.
Yeah. Yeah. And I also think just the community aspect of DHN, like it was this week where someone had shared an article around how even us, the people that work in the healthcare space, don't take care of our health or forget to do annual screenings. And very quickly, I think you rally together like a package for like annual screenings for members of the community, just to really be like, this is available.
Yeah.
Go doctors do an annual screening. Yeah.
So doctors too are very notorious about that. They don't take care of themselves. They take care of everybody else but themselves.
Yeah.
So that's one of the things that we need to be more cognizant of. For me, I get a lot of screenings because when I travel, I like to test other diagnostic centers. So I do get a lot of screenings.
Yeah.
And I don't mind needles, unlike some people.
Yeah.
So I get tested a lot, but that's also helped me be more conscious of my health because like I do a lot of my basic, and I've been able to find things I won't find out otherwise because of that. So it's very important to screen. So if you're watching this, please go get screened.
Yes, ideally at a Vegan Health Diagnostics Center. Wink, wink. But I want to talk about the broader diagnostics landscape. Most operators, well, we say at scale, but we say that everyone is subscale.
Subscale.
In Nigeria's organized diagnostics market today are linked to these international capital in some form, whether it's Ecolabs, whether it's Synlab, whether it's Clina Lancet or Seba Lancet. MDaaS is in that group of, a smaller group of operators, the number of centers. Yeah. The number of centers
in terms of number of centers right now, I think we probably have the most.
Yeah.
In purpose of, I know Synlab has more sample collection points. But in terms of like actually having a
Actual
proper lab,
centers, yeah.
with 25, we have the most.
Yeah,
And that's an indictment on the broader ecosystem that with 25 centers, you have the, meanwhile in Egypt, the biggest player has 750 or thereabouts. Same thing in South Africa, the biggest player has, I think, at least 500 or thereabouts.
Yeah.
So I think it's a bigger indictment of our sector, our subsector, that the fragmentation is so thorough that the top 4-5 players control less than 3-4% of the market. I think it's quite sad.
Yeah.
So yeah.
And there's a uniquely indigenous identity that maybe I associate with MDaaS. And MDaaS, the company is now profitable on a clinic basis across pretty much most of your clinics. I think the margins give your team enough room that I think in 2025 you opened 8 centers. And to me, that's like an outpacing story. Like there is a clear outpacing happening. I'm curious how you keep pace or outpace in a market where most of your large competitors have these international backers and things like that.
Funny enough, I don't see them as competitors, because that's not who I compete against. Yeah. So for example, so diagnostics can be split roughly into two major subsectors, right?
Yeah.
So you have the clinical diagnostics folks, and you have the occupational health, right? We are the only player that does both occupational health and clinical diagnostics at scale.
Yeah.
So we do a lot of screenings on the occupational health portion, where I think MedBree is the king of that. Shout out to Ituno. And on the clinical side, which on the SynLab, Sebalicense, who are lab only networks, right? I think the folks who we tend to compete, because in many of the places I go to, those guys don't exist there, right? They're not there. I compete with primarily mom and pop diagnostic shops in those places. In Lagos, we have maybe a few overlaps with SynLab, but in Lagos, I tend to do work with mostly occupational health in Lagos, except our Shangotedo location where we do some clinical diagnostics. But our other centers in Lagos are mostly occupational health.
Yeah.
But outside Lagos, right, our centers are usually the top clinical diagnostic lab or imaging center in many of the cities, right? So I don't see them as competitors. We operate. We working with two separate theses.
Yeah.
When you see the strategy that each player is taking is so different. From me, my next few centers are going to be in Kaduna, Sokoto, Maduguri, Calabar, right? And I'm going to, by the end of this year, we're planning 10 locations. We've done this to date this year. So we run into separate playbooks. They are mostly focused on Lagos, and teaching hospitals, working with teaching hospitals outside Lagos.
Yeah.
We are trying to be the centralized diagnostic department for small and medium-sized hospitals across the country.
Yeah.
In small towns, in smaller cities, in bigger commercial cities, in state capitals. That's what we're trying to do.
Yeah.
So maybe one day they wake up and say, hey, they want to do this too. And if they wanted to do that, welcome to the game. I think we need more people in diagnostics, because I think the more folks like SynLab come to those places, it also raises, because they bring the international profile to it.
Yeah.
It also raises the quality, to be fair. So they should actually try. This is a thesis they need to also do, where it's not just about optimizing for the big cities or the wealthiest who can pay the most.
Yeah.
Also trying to optimize for the mass market.
Yeah.
So we sit fully in the mass market bucket.
Yeah.
I think the closest in the bigger players is actually Union. Union is an historic. They've been around for at least 30 to 40 years. And we used to compete with them. We still compete with them in a few markets. And we compete really, really well.
Yeah.
So with them. And so and I don't know how Union are doing right now, but they're the closest. I actually compete with them in more markets than the Synlabs of the world and several assets of the world.
Yeah, yeah.
And in terms of patient numbers, we'll probably do more in patient numbers. We
Yeah,
might not be doing more as much of them in revenue, but in terms of patient numbers, just because we're truly mass market.
yeah, yeah. And so you said that your main competitor is mom and pops, and you have 26 company-owned clinics, but you also have affiliate clinics, which, from my understanding, are clinics that exist in the areas that you want to expand.
Yeah, mom and pops, pretty much.
Yes, that you then partner with. So it turns competition into collaboration.
Yeah.
So
In
talk
a
me
way,
through that.
in a way, it was a thesis we had 3-4 years ago when we didn't have the spread we have right now.
Yeah.
Where we were getting a lot of requests from our partners, HMO partners, corporate partners, to do work in certain places, and we didn't have a presence there.
Yeah.
So we had to go find someone who could do work on our behalf.
Mm.
But those sort of partnership have drawbacks, right?
Yeah.
Because number one, we're hyper optimized. Like, I ship in on my own regions, I ship in on my own equipments, I set up a lot of my own centers, so I can do the work at a cheaper rate that many of them can do.
Yeah.
So oftentimes with the affiliates, they cannot honor the pricing because of the cost base is much higher.
Yeah. Yeah.
You know, and so we kind of like, right now we still work with a few affiliates, but we're trying to replace with company-owned stores as much as possible.
Yeah.
Because I want to be able to go to Leadway or AX and say, this is the price of chest X-ray across my network.
I see.
Right?
Yeah.
Not just in Lagos and Ibadan, and then I will give you a different pricing in because I have an affiliate there, and they won't obey the pricing I agree already. So yeah.
Interesting. And I think one thing, as we talk about your pricing, I think MDaaS's pricing or Beacon Health's pricing has been positioned at the more affordable end of the market to really tap into that mass market. Does that positioning open up a meaningful public sector route? Like, are you already working with state health insurance programs or the NHIA or government referral pathways? If yes, how did that come? If no, is that on the
list
in the plans, basically?
So with we get referrals from some government facility across the country, because sometimes, like, we just opened in Ore, right? And we're the only proper diagnostic center in Ore. They have people that have, like, small shop labs, but we're the only proper diagnostic center in Ore right now. And so obviously we're going to get a lot of referrals from the general hospital there, because we are the only game in town. So instead of them sending people to Akure or Ondo town, the people can stay in Ore without traveling and get their diagnosis being done, right? So that's the big benefit of that. So
but any plans more meaningfully
to work,
because
so
I think
we've
being
embedded
in the mass
past
market,
so we're embedded in General Hospital Akodo in Lagos. Didn't work out. It just didn't work out for many reasons.
You care to expand?
No, I think that's the alignment. I won't obviously expand.
Yeah.
But there was a feeling that maybe we were making the money. We were losing money. To be honest, we were losing money there.
Yeah.
But even though we were losing money, there was a feeling on the ground that we were making a lot of money. Right?
Yeah.
But we did it because we also want to. I think one of the goals for us is, like, our work is to support hospitals.
Yeah.
And in many places, the government tend to have the biggest hospitals.
Yeah.
Right?
Yeah.
So if instead of me doing my own diagnosis center, you say, oh, let us embed within a government hospital, and it's a win-win situation. That's on papers makes a lot of sense.
Yeah.
But in practice, when people feel like, oh, there's money being made somewhere, and we were losing quite a bit of money there, but there was just that feeling that we were making money, and so people wanted more and more and more, and at some point I'm like, no, it doesn't.
Yeah. So
that's
there's this misalignment.
Misalignment
I think.
of finance. So that's one of those misalignment issues that we had.
No, makes sense. And I think we want to touch on the cure question now, because this is the question that obviously anchors every episode of this show. And it's what does revolutionizing the African healthcare business model look like? And specifically through the lens of diagnostics and through the question of what it actually costs to build, what does revolutionizing the African healthcare business model look like in a sector that is this capital intensive, this fragmented, this hard to fund, hard to scale? What would need to be true for a company like MDaaS to scale at the pace of the demand that's actually on the ground, that's not just visible, but also invisible?
I think when and I've said this publicly time and time again, I think one of the biggest problems we have is fragmentation, right? Fragmentation in the payment layer, fragmentation in the provider layer, fragmentation, everywhere.
Yeah.
So it means that everybody's we're optimizing for these little shops.
Yeah.
Which means that when a patient needs care and they go into a doctor for something, they have to pay there if they don't have an HMO, which most people don't.
Yeah.
And then when they need labs, they go to a different shop for that. They'll pay for something. Then when they need medication, they go to a different shop for it, pay for something.
Yeah.
Those three folks don't talk to each other. So you're paying the maximum at each location. There's no crop subsidization, nothing like that.
Yeah.
And at the end, by participating in if those three players talk to each other or are part of the same network in a way, the cost of care will come down for that patient.
Yeah.
But right now the patient pays the max, and so obviously in a poor country, that means that we're all struggling. The HMOs are struggling. The providers are struggling. The patient is struggling. We're all struggling.
Struggle nation.
So I feel like the biggest problem we can solve is the fragmentation. And I think there's someone that I can't remember their name now that wrote an article about, tech is where, fintech was 2013. I don't buy that.
Yeah.
I don't buy that. I think it's not about where it was. It was about the conditions, right? A single regulator that can direct the industry in a way. Motivated players who can do work in certain ways.
Yeah.
Are not allowed to innovate.
Yeah.
Obviously demand for the services. And I think in all of this, when you think about healthcare, even we have fragmentations in the regulatory. So you have the state regulatory folks you deal with. You have the MOH in Abuja you would deal with. You have the NHIA that most folks also have to deal with.
Yeah.
Like that also is one of the regulators. And then you have all of the bodies and the many bodies that will regulate you. So you still have that fragmentation there where there's not single point of power. I think the biggest thing I see when I think about two things, either our people get, we keep paying out of pocket, 70% keep paying out of pocket.
Yeah.
Now people just get wealthy enough
Yeah.
for us to fund the healthcare we need to build, which is obviously, that's a lot of faith to have.
Yeah.
Or we have like the NHIA, which I think should be that payment layer.
Yeah.
I think what you need is an orchestrator. And that's what we don't really have.
Yeah.
You have different orchestrators that orchestrate in their little tiny corners. You don't have the same orchestrator like CBN for the fintech sector that can orchestrate like at scale for everybody and say, this is how we do this. We're going to build an exchange, and this is how we talk to each other, so that HMOs don't owe money to providers, and then so that HMOs also are priced. The HMO plans are priced right.
Yeah.
And they have enough money to have operations and have some profits.
Yeah.
So that the providers also can be okay, and so that the patients can get good care without paying out of pocket.
Yeah.
And a lot of the orchestration now, the NHIA has empowered each state to do their own version of thing. That's even more fragmentation.
Yeah.
So that's what I'm saying. So the fragmentation question is what we have to solve for in any way.
Yeah.
The way we think about it, at least internally for diagnostics and now for primary care, which we've not gone far. We're still like thinking about it. Is that we need to build for what people can afford today. I can wait for the orchestrator to happen, but while I'm praying for that to happen, I will build for what exists today. And I do think in the diagnostic space, luckily, that you can build, that the demand is there across the country to build a really, really big diagnostics business. You need capital to build, which is something we personally struggle with. You need the capital to build at scale. And if you can do that, wait 2 years for all of the centers to mature. And you're going to be this massively profitable business in that case space that would now have aggregated or defragmented the diagnostic space. So that if any player, say AXA, needs to do diagnostics in any part of the country, they only need to come to you. They don't need to come to any other person. In a way, and that's what we're building for. Obviously, they might say, okay, instead of going to every single person, we go to maybe these 3-4 players that we trust. We trust not to defraud us, which is one of the biggest problems they have. And so when you're not thinking about fraud, you can partner more closely. So because I feel like a lot of the ways, the things that make care pathways suboptimal is because you have to think about, this provider might defraud me, so let me make it slightly tough for them. But by making it slightly tough for them to defraud you, you're also giving the patient a much, much worse experience. So it's about solving all of the things that are causing the fragmentation to happen. We're lucky that in the diagnostic space, I think nobody is building as many locations as we are building. And nobody is building in the places we're trying to build also. And so we think that it's a massive blue ocean. Which is crazy, because when we started, people was like, there's so many players out there, but by being in the space and doing the work we do right now, we think that it's a massive blue ocean. Whoever builds the first diagnostic center network to get to 100 locations is going to win the market massively. I'm not just talking about the outside the Lagos market. It's also that person is probably going to win the Lagos market also, because when you have that scale, you can walk backwards from it, right?
True.
Which is something we hope to do.
And you mentioned capital, and I would love to deep dive on what sorts of capital would be required to build that. So I think it was this morning, I was scrolling on LinkedIn or something, and I saw Tekabal release, it's part of their State of the Health Care industry, or health tech industry. Yeah. And there was a graphic that they posted that I saw the top funded health tech startups or healthcare startups or companies in Nigeria. And MDaaS was on that list. At the top of the list was like your Helium Health, obviously.
No, I think Reliance
and Helium.
54 Gen raised more money than Helium.
Well, that are still operation. But the top of the list was your Reliance and your Helium Health. I think it was like 40-50 million. And then MDaaS is on that list, and it's around 6 point something million across a decade of operations. And I'm curious, what kind of capital does it take to build what you're building? And what kind of capital are you looking for as you think of your vision from now where you are to your vision of 100 clinics? Because I read your kind of 2025 year in review, and you went into some detail on the types of capital that you're looking for. So I'm curious if you could just talk us through, from a capital and investment standpoint, what kind of funding does it take to build what you're trying to build?
So ideally, for the kind of work we're doing, you would say debt. But debt is expensive locally in Nigeria right now. That's just the honest truth. So in the absence of the sort of debt we need, what we really need is long-term patient capital. Long-term patient capital, mezzanine financing would be great. Which is like a long-term debt for 7 to 9 years.
Okay.
Type deal. That would be the optimal way, because if you can get that kind of debt, the centers actually pay for themselves. because the cost of building the center just becomes a financing charge every month on the centers when they mature.
Yeah.
Right. So in effectiveness, these centers will just build themselves.
Yeah.
Right. But someone needs to pony up that initial cash. So that's the big problem, is that we don't a lot of the capital we've raised VC, and VC, because it was such a risky business that nobody else would give us money.
Yeah.
But VC is risky capital,
Yeah.
and we're really grateful. We have some amazing investors who have given us over the years and supported us and our thesis, and I believed our thesis since. Because our thesis is not for the weak, and we've had people who believed it and who supported us with it and given us money to do it, to do that. So we're at the stage right now where VC is it's probably too expensive for us at the moment.
Yeah.
Just given that we also, as founders, we've sold a good chunk of the business to investors.
Yeah.
Where right now we're looking for more. We're still open to raising capital from players, but it has to be strategic people that can just bring more than money to our space, and that also are willing to be patient over the next 7 to 9 years.
Yeah.
About that. That's what we need. And if we get that capital, we can go crazy.
Yeah.
With the center build out, because we need to build with the way the business model works. You pretty much need to build and wait for 2 years for centers to mature.
Yeah.
Right. What that means is that the more you build today, your growth 2 years from now, you have to guarantee it today.
Yeah.
So if you want to grow 100% year on year, you know the number of centers you need to build to guarantee that. And that's what we've been doing over the past 2-3 years.
Yeah.
And so for the past 6-7 years, we've been growing 100% year on year. And so, but that's because we plan the growth.
Yeah.
By building the number of centers we need to build to guarantee the continued doubling of the business. And as you get bigger, the number of centers you need to build also increases,
Yeah.
because you're not growing from 1 to 2 anymore. You're growing to 500 to
Yeah.
so yeah.
And that reminds me of a term that I read in your 2025 year in review. I don't know if it was Genevieve that came up with the term, or it was you or your team, but you've written about thinking of the company in terms of being default alive first, and then now default growing.
That's Genevieve.
Yeah,
That's
okay.
Genevieve
I was right. Okay. So she's the mastermind behind that phrasing. These aren't terms most of our listeners will have come across. So I'm curious to understand what that means from your lens and how that ties into what you just described of what you need to kind of scale from now to your 100 center vision.
So the time, when the time Default Alive came into the lexicon was after the VC crash, and every investor was telling their portfolio companies that you just need to stay alive. Just try to become, because you might not get funding again.
Yeah.
So just do whatever you need to be alive, to be able to cover your costs, because in case if money doesn't show up, the business doesn't shut down.
Yeah.
And so when and people were very worried, rightfully so, because the ecosystem just lost a lot of the easy funding that used to come in. So at first we also bought into it and said, you know what, let's just try to just
be alive.
To be alive and just slow down a little bit. But for us, we were lucky. We were able to raise a little bit of money when we raised.
Yeah.
And so we're like, we don't want to just grow slowly and just wait till the money runs out. We're better at going to build instead and guarantee our future, and which is what we've done.
Yeah.
And by doing that throughout for a couple of years after that, where we've gotten to now is that even if we don't get funded, we are able to grow out of our cash flows, but it will be slower. But that's why, but because we want to go fast, we want to get to that 100 locations.
Yeah.
If I'm building out of my cash flow, maybe I build 2-3 locations per year. But if I get funded, I can build 20 locations in a year.
Yeah.
And so this year, we're building with a combination of cash flow plus a little bit of funding that we got. So that, and we're doing 10 locations this year because of that. But the idea is to be able to do 20 locations, 30 locations in a year.
Yeah. That exponential component requires that funding.
Funding, yes.
Okay. So we want to conclude our discussion looking ahead at part 3. So we've gone into part 1, we've gone into part 2. Part 3 is, in your investor memo, you describe part 3 as exponential scale through partnerships and data, with the ambition of becoming the largest integrated health network in Africa and cultivating the largest clinical data repository on the continent. And the benchmark that you cited, which I found quite interesting, is Quest Diagnostics in the US, which uses more than 20 billion lab results collected over a decade to support clinical trials, as we've discussed, precision medicine, and new diagnostic test development. So when you want to develop a new diagnostic test, you can access the Quest Diagnostics Bank to test that. I would love for you to give me your 2030. Well, 2030, I keep saying 2030 in all the episodes, but 2030 is in like 4 years.
4 years.
Give me your 2036, let's use a 10-year time frame, headline for MDaaS. Like, what is that front page, I don't know, headline for MDaaS?
It's probably going to be, a good one will be, Soga retires from the biggest diagnostic companies in Africa.
Early
Something like that.
retirement, love it.
Yeah. So that would be great. I will have done my time then. But some of these things that we put there as exponential, because when we came up with our investor thesis and memo, that was like 2022 actually. So it's quite 4 years ago.
Yeah.
That's when we wrote all of that. But we're doing some of those things already.
Yeah.
So we partnered with an European, very big European equipment manufacturer right now to develop malaria testing, because they developed a AI-powered diagnostic tool that they wanted to validate, and they needed our help with that. And so we're able to help them out with that.
Nice.
Obviously not free.
Yes. Yeah.
And we've seen a few opportunities like that has come up.
Yeah.
Like, where for us is we're building for all of the optionalities, right? The ability to be able to do clinical trials, the ability to be able to inform public health, what happens in the public health by using our data to help, the possibility for folks to do research with our data, because we have a massive data set.
Yeah.
Like every day now we see 700 to 1,000 people or thereabout, so it's significant.
Yeah.
And we're doing and we're also doing a lot of proper testing for folks, like across multiple pathologies, right? So we have something unique, and folks like Synlab probably have something similar, right? And I think there's an opportunity right now. We don't know the color of the opportunity yet fully, but we know that in the future, whoever has the biggest network will have this. Every day you add more to the data set.
Yeah.
Right. Every day is more information to your data set, and more information you can dig into to find insights to get something, to create value in one way or the other.
Yeah.
And so that's what we're building, really, is that some of those things we predicted in 2022 pretty much spot on. I know when I sent that to you, I read it and I was like, you know what, we're pretty right.
Actually done.
We're pretty right with this
Yeah.
thesis. And for me, we had more to the thesis, but the core thesis is the same.
Yeah.
It's never really changed. Is that like when you build something this big, number one, folks, and we've seen that you get network effects from the distribution. So one of our big thing now is we want to be in every single state. That's our most aggressive target. We want to be in every single state by end of next year. 36 of them. So we're building for it right now, and that's because we want for all of the HMOs that exist in Nigeria, for them to have at least one partner that can do work for them across the country. Right? All the national HMOs should have a partner they can work with across the country.
Yeah.
Where it doesn't matter where you are, like, where your beneficiary is. You can have a beneficiary in Zamfara.
Yeah.
And you can say, go to Beacon of Diagnostics in Zamfara and get it done.
Yeah.
And then your result will come in and look exactly the same as your results in Lagos. And then the HMOs in Lagos will trust that this is a quality result. I might not have been there before.
Yeah.
Is after to physically vet this diagnosis center, but because it's a beacon help, we know that we're guaranteed this quality.
Yeah. Yeah.
You know, and so that's the race we're running right now. The race to be in every single state.
Yeah.
In the federation.
Yeah. And you've alluded to this in today's episode. In 2025, you opened 3 primary care pilots under the Live
We
Longer.
shut down one already.
Okay, 2 under the Live Longer brand alongside your diagnostic centers. And you framed primary care as strategically as a demand generation and retention layer for diagnostics. It looks like another practical step toward your part 3, your vision.
Yes.
What have you learned so far? I mean, you closed 1 down, but 2 are still operational.
I learned that you would lose money if primary care. I learned the reason why it's tough. Primary care is tough. It's probably the toughest part of healthcare because people expect it to be free.
Yes.
So it's tough. And so even when you're trying to innovate in that space, people are not willing to pay money to talk to a doctor.
Yeah.
They're willing to pay for diagnostics, they're willing to pay for medication, but oftentimes people are not willing to pay for it. Particularly because they have like a doctor in their church, they can say, "God, Doctor Alpha, I have a date today. What should I do?" So, and some doctors also do consultations just because they are also serving their community.
Yeah.
So that part is really, really tough.
Yeah.
But I think that primary care is the price of healthcare. Whoever solves the primary care layer, that's the main price. But I also think that's the hardest price to solve. Just because you don't have that cash flow that you tend to get from, say, pharma or diagnostics. That being said, we have a lot of key insights from operating these locations.
Yeah.
One of the reasons why we shut down the one in Alaba was because it was inside the market. And the market is primarily male, and male are notorious for not seeking care.
Yes.
And then because it was so deep inside the market, the day they shut down the market, we cannot operate.
Okay.
Sometimes the market is shut down during the Christmas period for 1 month at a time. You cannot operate anything there. So it was just like didn't fit the cadence, and we were not for opportunities like that. You need the buying of the managers of the market.
Yeah.
And we didn't have the buying of the managers of the markets there. So you just had to shut it down. But I think that's something we keep learning about. We hope that the 2 things to solve for, I think this is my key thesis in case other people are building for primary care, I can share.
Yes.
So number 1 is that there probably has to be some sort of membership fee component and then so that people don't have to pay to see a doctor right away.
Yeah.
Which actually that's what typically happens in, they just call it card money, right? But a membership fee component with it, but then you need a lot of people.
Yeah.
So you need to figure out a way to get a lot of people. I think in each location you need at least 1,000 members to make it work.
Okay.
And we have not been able to get. I think our biggest location will probably have like 100 members. And so yeah. So that part is difficult.
Yeah.
But I'm grateful for Beacon Out who continues to support my passion projects.
Yeah. And you have experience doing hard things. I mean, building Beacon Health in the first place was not exactly
So Beacon Health
easy.
supports my passion projects. My R&D I'm doing on the side.
Okay.
For how do you scale primary care? I've seen a lot of interesting models, particularly in Brazil.
Yeah.
That I think could work in Nigeria because the model kind of solves for the fact that only 10% of Nigerians have insurance.
Yeah.
And when you think about private insurance, there's only maybe 2 million or thereabout people on private insurance, proper private insurance, not the government affiliated ones.
Yeah.
So there's a massive opportunity to provide a cheaper out of the pocket experience for folks when they want to experience primary care. Because people are using ChatGPT and going to their pharmacy right now, and there must be something better than that.
Yes.
And I think overall, I think the ChatGPTs are not necessarily. I think it's actually net positive, to be honest, because more people are finding out things about themselves they wouldn't otherwise find out, and they're talking to doctors about it.
Yeah.
So I think AI in that case is actually a positive thing because more people will actually come because they will find out more things about
But the thing with AI is the data that it was trained on, how much of that was inclusive of Africans?
Yeah, but I think I can talk about it for primary care. I think it gives you enough information to say, hey, I should probably talk to a doctor about this.
Yeah.
I've, to be fair, I've Googled symptoms with AI before. And oftentimes I'm like, let me call up a doctor and
confirm some of these. Yeah.
Because this looks scary, right?
Yeah.
So I think that more people would want to talk to a doctor. And so I think we need to bid for that world.
Yeah.
We need to bid for a world where people would have gotten some information from the LLMs.
Yeah.
And that they need to confirm or want to talk to a doctor now. And so that's what that having lived longer helps us experiment on stuff like that. So it's very interesting. It's
very
one of
interesting.
my fun. It was one of my fun projects because like with my with Beacon Health, it's like almost like a big business.
Yeah.
We're a big corporate now.
Yeah.
Or 400 people.
Yeah.
Which it's like sometimes it's just like HR issues there, this one issues here, that one issues here, supply chain logistics and whatever. But like, live longer is fun. It's like startup energy.
The startup energy you had back in 2016.
It's super fun to work on and build.
It's also crystallizing. I don't know if you're thinking about thought leadership. I'm always thinking about thought leadership. Some of the lessons that you're learning about scaling in primary healthcare, like the thesis, the insights, would be fantastic to kind of share and just put that out there broadly and kind of see what the reaction is to it, to see what other people contribute to it. Because I do think if primary healthcare is the prize, but it's the hardest prize, then as much information on what it takes and what the realities are on the ground would make that prize a bit more attainable. Like,
yes, I agree with you. I should write more. And that's one of my.
You used to write a lot. I read a lot of your Medium articles.
I used to write a lot back in the day, but when we're not deep in the deeper end of the business. It's a lot tougher right now. But that's something I want to do more of because I think it's really good. Because writing for me also helps me crystallize my ideas. So oftentimes when I'm writing, it's because I'm trying to form my own thesis about stuff. And I think writing helped me put my ideas, and then I need to run it through. Like I talk about this with Genevieve a lot, and so she puts my day through the grinder to make it come out.
She rips it to shreds and is like, okay, this is what's left.
So I think that's always a great thing, and I think we should all do more of it. Which is why I've enjoyed reading TCL Health actually,
thank you.
because you guys put in a lot of really well researched articles that it was few and far between before you guys came on, and so it's great to be able to read that was high quality research products.
Thank you.
So absolutely
much appreciated.
So
we've covered a lot today. It's been an incredibly rich conversation. I mean, we've touched on everything. I mean, we set out to talk about diagnostics, but we've talked about primary healthcare, we talked about funding, we've talked about all sorts, fragmentation in the system writ large. I want to close with a few rapid fire questions.
Let's go for it.
The idea of the rapid fire is I ask and you answer as quickly and as succinctly as possible. It's actually funny, you've answered quite a few of the rapid fire questions. Like one of the rapid fire questions was, what's the most remote Beacon Health location? But you already answered that earlier. So we'll start with the first one. You and Genevieve welcomed your second child last year. Building MDaaS with a toddler and a newborn at home. How does that actually work day to day?
It's not easy. It's not easy.
Yeah.
Because, you have to balance home life, work life. I think, but I think right now we've finally found a good cadence with it. Both Genevieve and I. And obviously, we're also on the ground more now. So it's really great to have the help. So yeah, but it's also like, these are like, MDaaS is kind of like our first baby.
Yeah.
So it's like,
it's three babies.
It's 3 babies. So you manage all of them together. And so but it's been fun. It's been really, really fun.
Yeah. One encouraging word for founders who are looking at the gap and realizing they will have to build the rails themselves.
Just do it. Yeah. I think that for me, it's like, always thinking from first principles. If there's no point going off this tangent if it won't work. So if you from your thesis you realize you have to build the rails, then just do it.
Yeah.
I think my biggest advice for folks is like, at least the way we try to do it at MDaaS is that we always focus on the biggest risk at any single point in time.
Yeah.
And so you don't, even though you need to build the rails, you don't need to build all the risks at once. So we started, even though we build a lot of tech right now, we didn't start building tech, because when we had 2 centers, tech wasn't the biggest risk.
Yeah.
You could manage 2 centers so we used Google Sheets for it to manage our clinical workflow. But when we had 4 or 5 centers, obviously, then the tech became really, really important.
Yeah.
So because people shouldn't be defeated by the fact that they would have to build the rails. You just need to build the highest risk one.
Yeah.
And then when you get to when you're done building it and you've de-risked that, then you build the next one. Then you build the next one. So for example, we only have our logistics business because we were using third parties to move samples up and down, and then the third parties guys preferred to deliver chicken and then blood samples. So we're like, okay, let's bring it in house to be able to do that. So you don't need to build that all at once. Oftentimes you can just build for the highest risk one and then move on to the next one. So yeah.
And since you're in diagnostics, the lifestyle disease you think Nigeria is most underprepared to diagnose at scale?
All of the liver and kidney issues that we're seeing right now. Yeah, because we drink all kinds of crazy stuff.
Agbo.
Yeah. So I feel like we talk a lot about diabetes. We talk about hypertension a lot. I think we're not talking about all of the liver and kidney issues that people are developing because of the things people consume. And I think that's really, we see a lot of that.
Interesting. One government policy that would change MDaaS's unit economics tomorrow?
Government policy. I've tried to build independent of government policy. That will change us, but for the better. If we move to a single payer system and we're vetted as one of the diagnostic providers for that, I'm chilling.
Yeah. NHIA, wink.
So that would change us fundamentally, because we still get people coming and can afford care. So that's the big problem.
2 more. The first one, finish the sentence. The biggest myth about brick and mortar healthcare in Africa is ...
Is that I think brick and mortar, people denigrate brick and mortar businesses in the healthcare space because they're not profitable. They think they're not profitable, but we have great margins.
You have great margins. You do.
Right? We do the work at a really high level. With those margins happen because we've built in a particular way. Like we are our own supplier of equipment and reagents mostly. Right, so that means that we make the margins on the reagents as a distributor, and we also make it as a diagnostic provider. So, but if you build in a particular way, there's a way to have great margins with brick and mortar. Sometimes when some of the non-profit folks see our margins, they were like, "What?"
Yeah.
But it's because we've built something really great, and we're grateful for that.
Nice, I like that myth. What gives you the most hope about healthcare in Africa right now?
What gives the most hope? For me, I think there's this realization post USAID cuts, post that nobody's coming to save you.
Yes, self-reliance.
That you need to figure out how to save yourself. And I've always believed that because when we started building, right, the kind of people that were working in our space and had a lot of opinion about what we're building were the folks that came from the foundation background, the public health folks, who are also very disease-focused folks. They want to focus on malaria, they want to focus on tuberculosis, they want to focus on HIV. But for us, our own thesis was around how do we support health systems as a whole, not just like this narrow disease vertical. So I think that in the end, everybody will be fine.
The thing that was meant to strip our hope actually gives the most hope.
So but I think that the fact that now everybody's like, okay, how can I make sure that I'm not dependent on certain supply chains, because if they cut funding, I'm really I'm really screwed.
Yeah, yeah.
And to say, okay, what are the alternate supply chains I can have? If you
Yeah.
have, for example, a lot of our government hospitals
Mm-hmm.
would have like top of the line Harbot machines there,
Mm.
right? But then that means that the cost of the reagents in dollars,
Mm.
you might not be able to consistently. Maybe the first government that did it would buy it. The
Yeah.
second government is like, oh, healthcare is not my priority. Then
Yeah.
you're screwed.
Yeah.
So it's about right-sizing everything to what it needs to be. And I
Yeah.
think that now those sort of conversations are happening finally. Now that there's no, sugar daddy somewhere to give you money for all these
Yeah,
things.
yeah.
So yeah.
I like that. I like that. Sugar, thank you so much for sharing your experience, for the work that you do and the MDaaS team are doing to put real diagnostic infrastructure in places that need them the most. I think I've taken a lot away from today's conversation. Defragmentation, I think, is ringing in my brain very heavily. What it takes to actually build brick and mortar, what brick and mortar actually means, and demystifying it in a way that, makes it feasible. And just some of the big picture kind of plans that you have for MDaaS. We'll come back in 10 years,
10 years,
and maybe
yeah,
we'll have you back on the podcast
it's
and
really all
see.
my pleasure.
Yeah.
Yeah, thank
But
you.
thank you so much. For our listeners, you can follow MDaaS Global. You can follow Beacon Health Diagnostics to see the work that they're doing across Nigeria. You can also read our piece on TT Health on oil pipelines, cell towers, and bottling lines for a deeper case on healthcare as a capital-intensive industry, where we spotlight MDaaS and what we can learn from other capital giants. One last note before we go, don't forget we're going to be at WHX Lagos 2026, taking place from the 2nd to the 4th of June at the Landmark Center here in Lagos. We'll be bringing you conversations with some of the most important voices in West African healthcare. So if you're there, come find us, and don't forget to register at www.worldhealthexpo.com. And lastly, don't forget to subscribe to The Cure and share this episode with anyone who cares about building the rails that make healthcare innovation possible in Africa. And Sugar, you sign off your investor updates, optimistically yours. And that is the spirit of this whole podcast and what this podcast is built on. So if you will indulge me, I will sign off this episode the same way. Optimistically yours, Tintobe Koka. See you in the next episode.
Thank you. This was great.
Yeah.
It's a great conversation.
Thank you. Bye.
Yeah.